Welcome back all the delegates. The next speaker for today is Dr. Ute Schneider, and the chairpersons for the sessions are Dr. Rabindra Naik sir and Dr. Shimsha Jacob. I request the chairpersons to please take your seats on the dais.
Good morning. It's my honor and privilege to introduce Dr. Schneider to the 58th Indian Orthodontic Conference. A short bio. She did her DDS from University of Mainz in Germany. She is a diplomat of the Italian Board of Orthodontics, specialty in orthodontics from University of Ferrara, Italy. She is a member of the Angle Society of Orthodontics, Eastern Component, has been the president of the Italian Academy of Orthodontics, also the president of the Eastern Component of EHASO. She is currently, in 2024, the president of the Italian Society of Orthodontics, SIDO. I kindly call Dr. Schneider to the podium for her talk.
Good morning. Good morning to everybody. Thank you for the very kind introduction. And before I start my presentation, of course, I would like to thank the Indian Orthodontic Society for this prestigious invitation, especially the president, Dr. Rahalka, and great compliments to the organizing committee of this convention because it's an amazing event. Sincere congratulations from my side. So, it's my first time in India. First time in Bangalore, and I'm very happy to share some insights of more than just a perfect smile with you today. I don't have anything to disclose. Just briefly to introduce myself, I'm from the northern part of Italy. Here you see the Dolomites that belong to the UNESCO heritage. We run an orthodontic office, my husband Lawrence and I together in Bolzano, which is a small city with 100,000 inhabitants. As you kindly already told the audience, we are members of the Angle Society and we teach at Ferrara University, and I have the privilege to teach also at Penn University in Philadelphia. Here a little impression how we work. We have 13 chairs. Our office is exclusively limited to orthodontics, so we don't have an interdisciplinary office, but performing just orthodontics. We are always relatively busy, and everybody loves what we do. We are keen orthodontists. We try to deliver an excellent service to all our patients, and we try to keep it as customized as possible. I cannot start any presentation without thanking my teachers and mentors, because without their help and guidance over all these decades, I would certainly not have been invited to this prestigious meeting to talk about more than just a perfect smile to you. And yes, of course, everybody that comes into an orthodontic office wants to achieve a perfect smile. But this is definitely not enough in patients that present with complex clinical situations. And what are complex clinical situations? Well, certainly patients that present with severe skeletal malocclusion, patients that present with missing teeth, obstructive sleep apnea patients, they present complex clinical situations, patients that suffer from periodontal involvement, and last but not least, the increasing, unfortunately, portion of patients that need retreatments. And all these complex clinical situations cannot be resolved by an orthodontist alone, but the orthodontist needs a team. And team is not just a four-letter word, it's an acronym you might know. Team signifies together everyone achieves more, and we really believe in that. Because we believe that it's our duty to deliver patient-centered care, which means that we have to come up with a differential diagnosis from day one. Together with our team, we have to do the treatment planning. We need well-orchestrated procedures in order to achieve our goals. We need to communicate intensively with the team members. And sometimes the treatments don't run as predicted, so we need joint problem solving. First of all, what we have to do is to define our goals. And for these clinical complex situations, we have to decide whether we're going to go for compensation or if we are going for the corrective side. I would like to start the presentation presenting you a patient I have found in the AJODO that was published in 2021, a patient affected by mandibular retrusion, as you can see, class 2, malocclusion, intraorally as well, deep bite, and arch length discrepancy. And the cephalometric analysis reveals, in fact, mandibular skeletal retrusion. So what are the goals in a patient with severe mandibular retrusion? Well, the trend, obviously, today is some sort of compensation by distalization, favored with skeletal anchorage devices, and in fact, the patient in the AJODO was treated by that approach. So compensatory treatment of the skeletal malocclusion by distalization. And this is the final treatment result that was achieved after a relatively long treatment time, 2 years and 4 months. And you can all see, yes, there's a class 1 intraorally, but still mandibular retrusion because this problem was not addressed. And if we take a critical look at the cephalometric X-rays here, we can all see that there's a significant amount of lower proclination. And I would like to ask you whether you like what you see here. And if you like the final profile, is that a treatment goal? Is that a perfect smile? Well, if we have a patient that presents with a similar situation after the growth spurt, like Julia, coming to see us at age 18, with a mandibular retrusion, our treatment goal is to maintain the inclination of the lower incisor as much as we can and to advance the mandible. This is the intraoral situation for class 2, as you can see, retroclined upper incisors. The goal, well, we can discuss about the goal. Are we going for compensation, which some of you might favor, or are we going for correction? And as you see here, we went for correction, which means that Julia had to endure a maxillary surgical approach with a genioplasty because we wanted to advance the mandible. And after the growth spurt, it doesn't work without performing surgery. So here you can see the mandible has been brought forward. We have a bimaxillary approach and a genioplasty in order to achieve the best possible aesthetic treatment outcome as well. So this is a screenshot from the dolphin system where you can see this is the final result intraorally, and you can also see that the profile, of course, looked much better. We have, I think, dramatically improved her smile. And not only her smile, but also the projection of the mandible. And that was only possible with that surgical approach. Of course, we have achieved a nice class 1. So let's take a critical look and compare the patient in the AJODO with our Julia, and there's a difference. I mean, this is undeniable. There is a better projection of the mandible with surgery. We were able to maintain the inclination of the lower incisor. We didn't have to camouflage so much. And of course, there's a difference when we take a look at the radiographs after treatment. And you already sense that this talk here is going to be about correction and not about camouflage, and you're right. So I would like to share 5 complex interdisciplinary patients with you during the course of my lecture, and we will start with an asymmetrical skeletal class 2 patient with dental wear. Again, a young patient, but after growth, Lisa, coming to see us at age 19, beautiful young lady with a not so beautiful smile. You can see the constriction of the upper arch, and you can see the retroclined incisors. You can see that she is bimaxillarily retrusive. She has a concave profile. There's a lack of projection of the upper incisors as well, and this is the intraoral situation where you can see more class 2 on the right side, and there's a little bit of asymmetry as well. Accentuation of the lower curve of Spee, and you can see there's some abrasion as well. Here you can see the skeletal asymmetry. The rami are asymmetrical, and I give you 5 seconds to make up your treatment plan. What would you do if she came to your office? Again, this is the intraoral situation, a little bit of profile here, view, and a little bit of the smile to help you develop the treatment plan. And maybe your idea is to go, like Mauro Farella has yesterday graciously shown us, a compensatory approach. And of course, you can go for full fixed or clear aligners with some TADs, distalization. We can use forces, we can use class 2 elastics. You can opt for carriere motion if you want. Or if you are not going for compensation, but you're going for correction, well, let's take a look at the profile and honestly, this is not the best profile possible, and I don't think we can really optimize that without, again, a surgical approach. So, of course, we discuss the options with the patient. It's nothing that is imposed by us. So all these treatment decisions are performed together with the patient. And if the patient decides to see the interdisciplinary team, also with the team from day one. So Lisa wants it done properly. Our treatment is very simple. In that case, we just need to dentoalveoli compensate. We have to achieve enough overjet for the surgeon in order to advance the mandible. We have to level and align the arches. This is clear. So this is our job. We decompensate. And after the decompensation, we sit together with the patient. And here you can see the before and the pre-surgical profile, and we're discussing. So we're explaining very simply so that the patient can understand it. Okay, Lisa, if we advance your mandible, your profile is going to look like that. But look at your nasolabial angle, it's still quite obtuse after this monomaxillary approach. So we think if we really want to achieve the best for you, you need a bimaxillary advancement procedure. And Lisa, after an intense talk, she opts for this solution. So here you can see her immediately before sending her to surgery, and here she is immediately after surgery. So she has just these stabilizing elastics. If you do your job properly, you prepare the arches well, then it's really a piece of cake for the surgeon to do this settling. And here she is after the removal of the appliances. You can see there are little spaces distally to the lateral incisors. Very often the lateral incisors are a little underdeveloped, and of course we have to take care of this because we're aiming at an excellent result. And this is the situation after surgery. Relatively good root parallelism, no harm in terms of root resorption. And here you can see that bimaxillarily the jaws were advanced, and there was some clockwise rotation also of the occlusal plane to increase the vertical dimension a little bit, and genioplasty was added to the procedure. And I show you the final profile, and I think that looks very harmonious. And here you can see the soft tissue changes due to this bimaxillary approach. And of course, together with that comes the improvement of the smile. You can see a nice consonant smile arc. You can see that we have a little expanded the dental arches. You can see much better projection of the lips, of the teeth, of the jaws. And what else? Well, we have many patients, even young patients, that present with dental wear. And this is the case in Lisa as well. You can see that the upper and the lower anteriors are subject to dental wear. And yes, we have to take care of that. And not only for aesthetic purposes. Sometimes we send the patients, if they can permit it, or if they have the financial possibilities, to the restorative dentist. Here, financial problems were at stake, so I did these composite restorations after the removal of the appliances for her in order to save money. And we have to take a critical look at the lower arch as well, not only for aesthetic purposes, but for function. So, of course, everything looks nice once we have restored the upper and lower incisors, and we have also restored the cusps. But this is not the only goal. Of course, this is what we would all like to see on a regular basis in all our patients: nice interdigitation, well-leveled arches, nicely rounded out arches. But the goals are not only to achieve an optimal aesthetic result, but we want to achieve good function as well. Of course, we all know that the patients come to see us in the first place for smile improvement, and we have to deliver that. We have to value what our patients want. But what is also very important is good function. And so we believe that this is the prerequisite for long-term maintainability: slight interincisal and slight canine contact. This is what we need to secure the maintainability of our treatment results in the long term. So never forget, form and function is one entity. Second patient, severe skeletal class 3 patient. This is Barbara. Unfortunately, coming a little late to us at age 13, you can all see that she suffers from a class 3. This is the screenshot of our dolphin system. And you can see there's arch length discrepancy. There's an asymmetry as well, so quite a demanding situation. There's already proclination of the upper incisors as a compensatory mechanism for the skeletal class 3, and we have a width of -9 at age 13. And here you can see that we have arch length discrepancy in the upper arch as well, so the canines, they have a little difficulty to erupt. And of course, we have to define what our treatment goals are. Trying compensation in Barbara, age 13 with a width of -9, or are we immediately thinking, well, this can't be done without surgery? You know, by the publications of Hugo de Klerk and others, that, of course, with these devices, and I see that Dr. Liou is here in the audience, that we can achieve remarkable advancements of the midface with these mechanics. Absolutely. And this is the latest, probably, by Nur Taraf and the Australian group. They compared the traditional approach with RME and face mask to the skeletal expansion with full-time wear of class 3 elastics to the mento plates. And yes, this mechanics increased the skeletal effects and reduced dental side effects, but we don't know yet if this is going to be maintained in the long term. So after these approaches, usually we have to cross our fingers and hope and pray that growth is not going to ruin the nice intermediate result. And there's evidence, again, coming from Australia. This is Marie Cornelis, and she has performed a meta-analysis, and she could evidence that the quality of the research not so good, that the A and B improvement is not so great, and that in the end probably we will end up with a 1 millimeter of width improvement, which in Barbara is definitely not enough. I think you will agree on that. So what we are going to do for Barbara? Well, first thing we have to do is to create space for eruption of the canines. And we already have this proclination of the upper incisors. Treatment approach, old school treatment approach, we're going to extract 2 teeth. And then we are just monitoring her. We don't do anything because we don't want to challenge our patients too much with collaboration and with 20 appliances that in the end probably don't work. So we're just securing that the canines are erupting, and we monitor her once a year, and we let her grow, and of course she continues unfavorably. That was expected. But then comes the time, age 15, when the teenagers, they look in the mirror and they consider their aesthetics as being very important, and the same happens to Barbara. So she is back and says, I'm not happy with my smile. I don't like that diastema. Can you do something for me? And yes, of course, we can fix that in no time. We can use clear aligners, or we can use just upper braces in order to close the diastema, and in parallel we can round out the upper arch a little better and rotate the canines, but we are not trying to correct the malocclusion. So in 6 months, what she requested was performed. So no diastema anymore, no attempt to correct the skeletal problem. And we monitor her until we know that there's no growth anymore. She comes back at age 18 and is now ready for surgery. What are we going to do? When are we going to perform surgery? Well, there are 2 options. First, the traditional approach. We prepare the arches, and then we send her to surgery, or we can opt for a surgical first approach. Surgery first, I think there are speakers here that are going to address it, so I'll be very short about that. Has 2 great benefits, an early facial improvement, and we can use the RAP phenomenon, the regional acceleratory phenomenon, which means that after surgery, teeth move faster. Old school orthodontics in Bolzano, so we sometimes perform some plaster models, we handheld them, and we see if the arches are matching. And they are matching well, so indeed, Barbara could be a good candidate for surgery first. And this is the time then when we send her to our surgeon, and of course he does a solid 3D digital planning, otherwise it's not possible, for bimaxillary surgery. First simulation, and of course we need a wafer that has to be constructed on the basis of this 3D digital planning. Then Barbara comes and decides that she wants to have the surgery done during the summer vacations, which is good because this is very plannable. We are placing our brackets. We're not placing any arch wire before the surgery, just bracketing her, and then here she's back 2 weeks after surgery. Of course, she cannot open the mouth very well, but we can at least insert some arch wires. And we're using this wrap phenomenon, so we can see her earlier and change the arch wires more frequently. And here you can see after 8 weeks, everything looks already very good. And here she is 5.5 months after surgery and ready for debonding. So 5.5 months later, appliances are removed. Of course, yes, this is again bimaxillary surgery and a genioplasty, but very efficient treatment. So we had a very short phase 1, 6 months, then a long, long, long waiting time. We didn't burn her collaboration and her energy. And 6 months phase 2, okay, surgical approach, but everything done in 12 months. And this is what we call an efficient treatment, and this is what our patients want. Nobody wants to be treated forever. So the little story here, efficient orthodontic surgical treatment in 12 months, first phase, second phase, and you can take a critical look from the lateral aspect as well. Of course, we have achieved nice class 1 occlusion, we have centered the midlines, we got rid of the asymmetry. This is when we remove our appliances, and this is what we would like to see on a regular basis in all our patients, and definitely an improvement of her face, of her smile, projection of her jaws, projection of the incisors, much nicer smile, consonant smile arc again. And here she is 3 years after the end of treatment, and it seems that everything is very well maintained. So surgical first approach, yes, might be faster. You can reduce the treatment time by 6 months. Creates the same satisfactory outcomes like the traditional surgery, is very highly accepted by the patients, and the complications, at least that's what the literature tells us, are comparable. But not every patient is a good candidate, so careful selection of the patient is mandatory. We need precise treatment planning, and we have to have a good collaboration with our surgeon. Third patient. Hemimandibular hyperplasia. This is Davide, and you can all see significant skeletal asymmetry coming to us at age 17. I was almost 18 when he came to see us. You can see the asymmetry of the smile. You can see the asymmetry very well from this oblique view. The right and the left part of the face are completely different. There's a brachiocephalic pattern underneath, and yes, the intraoral situation looks like this. Asymmetry as well. You can see a very steep, especially lower curve of Spee. You can see abrasions as well. Retrusive upper incisors. You can see on the left side he's full class 2 canine wise. You can see that there is significant arch length discrepancy, especially in the lower arch, and not only if you consider the second premolars that are extremely large, but there's also posterior crowding, which sometimes is not even put into the equation when you do your treatment planning. You should always look what is happening in the back of the mouth as well. And this is the radiographic situation. You can see that there is that hyperplastic left condyle, and even the 2D radiographs, they evidence this massive asymmetry. And as I said before, he is a deep bite patient as well. And yes, of course, we need 3D radiographs in order to come up with the treatment planning. That is correct. I have to admit we are not performing 3D radiographs in every patient in Bolzano. We are very cautious. We adhere to the ALARA principle, but of course in Davide we need a CBCT in order to diagnose and treatment plan him correctly. And the surgeons, sometimes they want these stereolithical models, and yes, of course, you can do that only with 3D technology. So what are we going to do? It's going to be a first step of surgery with a condylectomy, and the surgeon said we need a low condylectomy with neck preservation for Davide, and this is after the first treatment, surgical treatment, low condylectomy performed, and yes, of course, this already has improved the asymmetry, as is clear, but still a lot of asymmetry still present after this first condylectomy approach. Still an asymmetrical smile, projection of the mandible, and the teeth is not ideal, and still we have a significant problem to face in the second phase of treatment. What are we going to do? How are we going to tackle this second phase of treatment? What are our treatment goals? Well, again, I would like to show you a patient that has been published in the AJODO in 2021 by this screen group. Again, a patient with hemimandibular hyperplasia. You see the intraoral situation is a little less difficult to manage than Davide. I think you will agree on that. Anyway, the operators have opted for, first, a condylectomy, like in Davide, and then, in order to prevent a second surgery, they have performed a camouflage treatment using mini plates in the maxilla, in the first quadrant, in order to compensate the rest of the asymmetry. So this is definitely the new trend. Mini plates, mini screws, in order to avoid another surgical approach. So I would say a compensation, successful dental compensation. But if we take a critical look at the before and after smile, I don't know. Are you satisfied with that treatment result? Would that be your treatment goal? Well, I'm not so convinced. And so we treated Davide in another way. What did we do? Well, we have this dental problem to face as well. We have arch length discrepancy. We have these massively increased, accentuated curves of SPE. We have abrasion. And what are we going to do? Well, we still extract teeth in Bolzano. And you can see we have opted for extraction of the second premolars. And very traditional mechanics, straight wire. And have to express my deep compliments to Paula Merlo. Yesterday, a very nice presentation where she reminded us that straight wire is great, but very often we need to have some accessories from the segmental arch technique in order to be more efficient or more effective. For example, here, uprighting of the molars and maintaining the inclination during the closure of this large extraction space can only be performed with these uprighting springs that help also to level the curve of SPE, and sometimes they are great also to increase the anchorage. So don't forget segmental arch techniques, even if you are the straight wire guys. So before the second operation, we were able to level and align the arches well. We closed the spaces nicely. Of course, we didn't correct the asymmetry because we thought this has to be addressed with a second surgery. And here is Davide pre-surgery. Of course, the significant asymmetry has to be resolved, and this was resolved with the surgery. You can see a good class 1, right and left. We can see the centered midlines after the surgery. Then we need, before we remove the appliances, if the roots are parallel, we need rebracketing. I have to admit we're not perfect. So on a regular basis, we perform panoramic X-ray before we debond. And here we have to open more space because you can see there are abrasions. And as I said, it's mandatory for long-term maintainability that you consider these abrasions as part of our treatment planning. So deliberately opening the bite for future restorations of the worn incisors. So this is after appliance removal, and this is after the restorations with composite. Again, financial issues, so I did it after removal of the appliances. If the patient can afford a good restorative dentist, we have excellent restorative dentists in Italy. We're blessed with excellent restorative dentists, but sometimes money is the issue, and so I did it myself. I hope you like the final treatment result from the frontal aspect. And again, I would like to emphasize that taking care of the abrasions, and you can do that with composite material alone, is absolutely important to achieve this light incisal and canine contact. This is the prerequisite for good function, and you should check function before you remove your appliances. So canine rise and incisal guidance is still a treatment goal today, even in the era of aesthetic hype. So before and after, a little bit of gingivectomy if you're really picky with your excellency. And this is the before and after. Of course, a big difference in the symmetry correction. We gained a little bit of vertical dimension, again with the bimaxillary surgery approved. And of course, there's a nice improvement of the smile. You can see that the arches look nice. We have not overpowered the periodontium, which is another important aspect to consider in treatment planning, that we don't want to jeopardize the integrity of the periodontal structures. And yes, we have achieved class 1 on both sides. Here again, the little story. It was a 2-phase surgical treatment approach, yes, but that was necessary in order to come up with a correction of the skeletal asymmetry. We have better projection of the upper and lower jaw. I think you will agree on that. We have gained a little bit of vertical height as well. And if we compare the first patient and the second patient, the smile after treatment, I mean, there is a difference. And compensation is good, but sometimes your patients need surgery in order to make them really happy with the treatment result. Another patient, very interestingly, obstructive sleep apnea patient. It's an increasing portion of patients that come to see us with that problem, and very often they are referred to us by the ENT. And that was the case in this patient as well. Patient felt always tired in the morning. He performed polysomnography, and that polysomnography revealed an increase of the apnea-hypopnea index, not dramatically, but there was an increase. And together with the request of a functional improvement, he said, I don't like my smile. So request to fix both the functional and the aesthetic aspect in this patient here. I think if you're a little acquainted with OSA, with obstructive sleep apnea, you can understand that this is the typical OSA profile. Significant mandibular retrusion, significant, and you can see as well that there's some retroclination of the upper incisors. And that is because the patient had already been treated orthodontically some years ago, and obviously the idea of the treating orthodontist at that time was to go for compensation by extracting 2 upper premolars. And yes, we have a class 1 relationship canine-wise and a full class 2 molar-wise, but of course this has not resolved the underlying skeletal severe class 2 malocclusion. And this approach to just extract 2 teeth in the upper arch has not resolved the crowding in the lower. We have an accentuated lower curve of Spee, and again we have abrasion. And here you can see on the cephalometric X-ray that we have significant mandibular retrusion. There's 10 degrees of A and B. And with all that, we have a long diagnosis to perform, or as Birte Messen says, a long problem list. Really a long problem list. We have to evaluate, and of course the treatment plan has to be formulated accordingly. And what we would like to perform in all our patients is this here: evidence-based practice, which means that, of course, we need a lot of clinical skills, but we have to include the best available research in our decisions, and of course, we have to value what our patients expect from us. Literature tells us that surgical maxillomandibular advancement is effective and safe long-term for most patients with moderate to severe OSA. And I have to tell you that the patient already had a history of these nighttime wear mandibular advancement removable appliances. He didn't like it at all, never wore them, so this is absolutely not a treatment option for him at that stage of his life. And you can see that we can achieve an increase of the pharyngeal airway with this procedure. And together with a request for a massive smile improvement, a facial improvement, and aesthetic improvement, we thought that this would be the right way to go. But of course, we have to prepare the arches before we can send the patient to surgery, which means that he is already lacking 2 premolars in the upper arch. We have to perform compensatory extractions in the lower arch for dental decompensation. We have to harmonize the arches before we send him to surgery. And then a bimaxillary advancement procedure is necessary together with a maxillary expansion. And then again, restoration of worn incisal edges and cusps and retention. And here you can see the patient prepared for surgery. You see the massive increase of the overjet, which we could only achieve by extraction of 2 premolars in the lower arch. Here you can see the the arch form harmonization, and this is, of course, what then increases the overjet. We take a critical look at the cephalometric X-ray, and yeah, again, you can do it digitally, you can do it analogly. You have to be sure that the arches are going to match during surgery, and then it's the right time to send the patient to the surgeon, who again performs, of course, 3D treatment planning, which is going to be bimaxillary approach and a genioplasty. And here's the patient after the surgery. You can see that both the maxilla and the mandible have been dramatically advanced. And of course, this helps then to achieve a nice interdigitation. We have class 1 canine and molar-wise. We have a good inclination of the upper and lower incisors without overpowering the periodontium. There's a massive improvement of the profile. You can see that he doesn't look so tired anymore. I think this is quite astonishing here, that you can immediately sense he seems to breathe better. These are the arch forms before and after treatment. And again, always this focus on restoration of worn incisor and cusps. This is mandatory for long-term stability. And yeah, we're able to level the lower curve of spine nicely, and periodontal aspects are important to include in the treatment plan as well. So definitely an increase of the smile width, definitely better projection of the maxilla and the mandible and the teeth. And yeah, there's evidence in the literature that tells us that surgical maxillary expansion can reduce the apnea-hypopnea index and, which is important and a special request for the patient, can improve daytime sleepiness. And this is what I showed before, the increase of the pharyngeal airway, and not only of the airway, but we have a significant improvement in the quality of life of our patients. And this is what our patients expect. This is patient value. So 24 months now in retention, everything seems to be well maintained. I think you will agree on that. Patients still happy with the decision. Recently performed another polysomnography, and there was a positive repercussion, and you can see there was a reduction of the AHI from 20 to 3. Last patients, 2 patients for the increasing portion we see in our office, patients that require retreatment after 1 or 2 prior orthodontic treatments. And probably this is a little bit due to this great wave of clear aligners that is sweeping across the world, and with more and more general practitioners performing orthodontic treatment. And sometimes orthodontists that are not able to manage the biomechanics of clear aligners so well. Exemplary patient coming to us after more than 2 years of clear aligner treatment. She's from Bolzano, Sabine. You can see asymmetric class 2 malocclusion due to an asymmetric mandible. You can call that class 2 subdivision if you want. She's missing the lower first molar in the 3rd quadrant, a bit of crowding, and of course she wanted a smile improvement. That's what they all want. She thought she couldn't get that in South Tyrol, in our area, not in Bolzano. So she went to Munich, in Germany, for treatment. So every 6 weeks or every 8 weeks she was traveling. And here's the treatment result after 26 months and after having spent 6,000 euro for the treatment. And she's absolutely not happy. She's absolutely not happy. You can still see the attachments. So this is what happens when patients are not happy. They come with the attachments in the mouth for second opinion. She's not happy with smile aesthetics. She's not so happy with the arch alignment. She says, still some details that I don't like. And she's absolutely not happy because she doesn't know where to bite anymore. She says, I feel so insecure, I don't know where to bite. It was much better before I started treatment. And I think if you take a look at the occlusion before and after this phase of treatment, she definitely was better before. But it's true what Lyle Johnson says. I hope you all know who Lyle Johnson is. He is one of the gray eminences of evidence-based orthodontics. He says, as nobody dies from anchorage loss, data are besides the point. And florid advertising is all that's needed. And unfortunately, this is true, because this here is not a treatment plan. This is not a diagnosis. This is just a tool. It's a tool. And what we need is, first of all, a solid diagnosis, and then a treatment plan, and then we can choose our appliances accordingly. At least this is our way of performing orthodontic treatment. So first thing that Sabine needs is a diagnosis. What is the diagnosis? Well, we have to take everything into the equation, and so the diagnosis or the problem list for her is really long, because she has skeletal problems, dental problems, she has a thin periodontal biotype, she wants total improvements, not only smile improvement, facial improvement as well. She's really a difficult patient. And of course, we have to value what our patients want from us. She requests improvement of smile aesthetics. She wants to improve facial aesthetics as well. And she says, please fix my bite, because I don't know anymore where to bite down. So again, long diagnosis, long problem lists require a long and comprehensive treatment plan. So we have to get rid of all the associated aspects that add up to the problem list she has. And I'm fast now because I want to share another patient with you too. So again, it's a surgical approach. First of all, pre-surgical orthodontic decompensation. We have to gain space for the surgeon to perform the mandibular advancement with the asymmetrical advancement for centering of the midline, because this is a skeletal problem she has. Of course, we have to round out and align and level the arches nicely. We have to gain more overjet. And here, just to be very concise, pre-treatment, pre-surgery, we increase the overjet. And here she is immediately after the end of surgery, when she was removed from hospital. You can see we have achieved a good class 1, nice inclination of the upper and lower incisors, and she's ready for the removal of the fixed appliances. But of course, her treatment is not over there, because there are a lot of things that have to be addressed after the end of orthodontic treatment. For example, new composite restorations, everything has to be redone. Bone grafts and an implant bone crown on tooth 36. It's still a long procedure, okay? So the periodontics has to be prepared for the implant, and then comprehensive prosthodontics have to be applied. And she's a periodontal thin periodontal phenotype. So she needs grafting. And all that takes time and costs a lot of money. But this is the way how things have to be done if you perform comprehensive evidence-based practice in your patients. And so before, after removal of the appliances, and now this is where she is at the moment. Of course, again, a surgical approach. Professor Raffarini from Parma, he advanced the mandible asymmetrically in order to get rid of the skeletal asymmetry, in order to get rid of the skeletal class 2 malocclusion. We have an improvement of the profile. We have an improvement of the face in the frontal aspect as well. We have a much better projection of the upper incisors. I think you will agree on that. We have an improvement of her smile. This is what she wanted. Of course, everything looks much better after our comprehensive interdisciplinary treatment. I go very fast here because I have to save some time. And here you can see where she is now. And you might criticize, Dr. Moser, what is this here? There's still a crown that has to be redone, and there's some grafting that has not been performed. And you're right. But all these things take time and, of course, money. So sometimes you have to give the patients time to save money in order to perform the treatment until the very end. But this is what she came for in the first place, what she wanted. And so in order to perform evidence-based practice, sometimes you have to be a little patient with your patients and with yourself. But this is the way how treatment should be performed in the best interest of the patient, if this is what the patients request in the first place from you. So it seems that I were against aligners. This is absolutely not the case. We perform aligner treatment in our office, but we see a lot of dark sides of bright things nowadays. We have so many second opinions coming in. You have no idea. I think every second visit is a second opinion patient nowadays. Like this patient here, I apologize for the records. The former 2 orthodontists did not want to share their electronic files with us, so a patient came in just with a printed out record sheet here. But you can all see what the problem is, I guess. That was before she started her aligner treatment, 2 aligner treatments 4 years ago. Significant skeletal class 2, dolichofacial, already proclination of the lower incisors, full class 2. I mean, you see it with yourself. And so in these patients, you have to critically evaluate if compensation is an option or if you have to propose a surgical correction in the first place. I just share how she looks today after several rounds of clear aligner treatment and going for compensation. And I think that's really too much of compensation, because this is where she started and this is where she's now. And this is the intraoral situation. This is not evidence-based practice, I guess. We can agree on that. So if you choose compensation, please choose wisely, and choose wisely the appliances you are going to use. Because, again, these are tools and no brain surrogate. Okay? And yes, you can use aligners very well. This is a patient, one of the first aligner patients I treated in 2013. It's a teacher coming for a nicer smile. And yes, of course, you constricted upper arch, and there's crowding, and there is some arch length discrepancy as well. You can see there is significant retrusion of the mandible. This is full class 2 intraorally. She has lost some teeth. Why? Because she didn't care a lot for herself due to a breast cancer history, a recent breast cancer history. And so, yes, of course, you can round out the arches, prepare her for surgery. You can do that in order to make her happy with her smile. This is what you can do with aligners very, very well. So from a frontal aspect, it might be even enough, but from a comprehensive standpoint, absolutely not. So even if you have patients that have a medical history, you have to convince them to go the right way with you. And therefore, again, you sit with the patient, you explain what needs to be done. You don't have to change your mechanics, you just apply some bonded buttons in order to be able to apply class 2 elastics after surgery. Here she is 6 weeks after surgery, and after 15 months, she is ready to see the prosthodontist. After 22 months of treatment, she's ready. And of course, you can use aligners in order to achieve that, but you have to do the right things right. You can use digital technology for quality control afterwards. And here I'm very happy to present that she's cancer-free and that the result of the treatment has been very well maintained over time. Very short conclusion of my talk to explain once again that for us, it's very, very important. Just as Flavia Atese, she's the president of the next IOC in Rio, and she all cordially invites you to attend her conference, said in an editorial in one of her journals, in the future, orthodontic practice will be limited to high complexity only. So we have to be very well educated, more profound than in the past, to treat all these difficult patients efficiently. And Lai Johnson, again, he is right. Orthodontist is becoming a multi-level calling. There are the easy patients and the providers that wanted the easy way, the cosmetologists, but on the other hand, there will be an increasing portion of patients that need skilled evidence-based practice. They want perfect treatments. They want quality. And therefore, the future of interdisciplinary teams is bright. They can perform joint diagnosis and treatment planning, continuous communication. They help to do problem solving, joint problem solving, closely interact, especially during the finishing phase. And they want to achieve even better patient-centered care in the future. And I'm very happy that we have a team with which we collaborate since many years. I would invite you, this is a free open access issue of the British Dental Journal. If you're interested in interdisciplinary treatment, for 1 month you can access it for free. Perry Fleming, the editor, has invited teams to contribute to this issue, and so I invite you to take a look. You find a lot of interesting ideas there. And as the president of CEDO, I would like to invite you, probably it's a little late because it's in 1 month's time, to join us in Florence next month, because we're continuing to talk about interdisciplinary treatment, about excellence, about the future in orthodontics, of course, and I'm very happy that we will have the first female leadership summit there in order to support this NPO for their battle against violence against women. And I'm sorry to be a little late, and thank you very much for your kind attention. Thank you so much.
Thank you, Dr. Schneider, for that excellent presentation. You've shown how effective treatment planning, diagnosis and treatment planning And multidisciplinary dentistry can resolve even the most complex cases, and that it's not just treating a smile, but form and function go hand in hand. Thank you so much. Any questions from the audience, please? If there are no questions, we come to the end of this lecture. Thank you.
Thank you.
I request Rabindra Naik sir and Shimsha Jacob ma'am to give the certificate of appreciation and memento to the speaker.
Good morning. Professor Dr. Eric Liou is Associate Professor in the Department of Craniofacial Orthodontics and Graduate Institute of Craniofacial Medicine of Chang-Gung University, Taipei, Taiwan. He is immediate past president of Asia Pacific Orthodontic Society. He is editor-in-chief of APOS Trends in Orthodontics. He is ECM of World Federation of Orthodontics. His main academic researches and presentations are mostly on temporary anchorage devices, class 3 malocclusion, orthognathic camouflage treatment, treatment of occlusal cant, and facial asymmetries with yin-yang arch wires, maxillary orthopedic protraction, surgery first orthodontic approach. Dr. Eric Liou, we welcome you at Indian Orthodontic Society, Wasabi Memorial Audition. The stage is yours. Thank you.
Thank you very much. It is my great honor to be invited to give this oration. And today I'm going to share you how I treated class 3 patients and also facial asymmetry patients without surgery. Well, when we are talking about class 3 treatment, most of the time we will call that a camouflage orthodontic treatment. But wait a minute, are we camouflaging something? No, we are not. So what we always do is, for example, I put a taste in the lower, and I do total arch distalization in order to improve the anterior crossbite. This is what we always do for those camouflaging orthodontic treatment in class 3 patients. But the question would be, I'm sorry. This is not working, okay. The question will be, why we keep doing this camouflage treatment? Because we don't think we are able to change the jaw-bone relationship without surgery. Is that true? Well, we are not able to change the length of the bone, but don't forget, actually we are able to change the position of the jawbone, especially the mandible. This is not really working. Okay, so for example, we have a class 3 anterior crossbite here. So for this, I do believe, yeah, that's simple. You can either put teeth in the lower, or you don't need it, you can do TP, or lower anterior teeth and tip the upper anterior teeth forward. Okay, I can. So in this case, actually, I spent a very few time. I was able to finish the patient. And actually, this is the case I keep using all the time. Why is that? Because I'm not doing this anymore. Because this only gives you a good occlusion, but in terms of face, Look at him. This is the patient. Before and after, do you know which one is before, which one is the after? Not really. Class 3 profile is still there, although the occlusion is good. And look at his smile. His upper incisor shown actually is not good enough. The chin projection is still too much for him. So giving the patient a good occlusion doesn't mean the patient gonna have a good profile. For me, it should be opposite. I would like to give the patient a good facial profile, then the occlusion will be there. Since if you are giving the patient a good facial profile, that means the jawbone relationship will be correct. Once they put the jawbone correct, the bite, the occlusion automatically will be there. But the question will be, how could we improve the patient's face, especially for mandibular prognathism patients? Yeah, we are able to do the bite, but the chin and the face, how is it? Very simple. What I'm doing is just that little blue biorazor. Just that. Not a fancy device before. You see, we've been using bi-block, bi-turbo, we call that, no matter how you call it. But anyway, I prefer to call that as a biorazor. In actually, that is a single tooth occlusal spring. Later on, for the facial symmetry, I will explain why I call that single tooth occlusal spring. I make it from glass ionomer band cement. You can put it in upper or either lower. But if the patient had canting, it's better put it on the non-deviated side. But don't forget, because that is a byproduct. When the patient bites, that will intrude the molars. So also they have a molar, the side effect is a molar intrusion. In order to prevent that, you can do TPA or lingual depends on where you put it. Of course, because of the molar also were intruded, it's better to have the patient come back every month so that you can put it on layer by layer each month. A lot of patients ask me, do I have to put that on both sides? Well, you can put it on both sides. Now I prefer to put it on one side only. For example, I put it on number 27 first. Then I will see intrusion of the 27. Then I move to 17 and let that 27 erupt. Or I can move to 37 or 47. So overall, I have 4 teeth taking turn to go for that purpose. The single tooth occlusal spring could also be applied in either growing patient, in adult patient, and also in aging patient as well. And this technique actually, in the beginning, I have published this in APOS trend in orthodontics in 2018, and later on in 2022, AZODO. And I use that to redirect the growth of the mandible in growing patients. So the example here on your left side, that is a patient without using biorazor. On your right side, that is a patient with the biorazor. You can see his mandible actually going downward instead of going forward. But that patient without using biorazor, the mandible grew forward and downward. So actually, we are able to redirect the growth direction of the mandible, although we are not able to decrease the length of the mandible or the growth of the mandible. Here is one of the examples. You can see class 3 patients. After treatment, after 3 to 4 years treatment, you can see his mandible stay there without going forward. And the smile actually is much better than before. And look at the CT scan. The superimpose showing that the mandible grew downward only. There's no forward movement. And that is the way that we are able to control the growth of the mandible. but not the amount of the growth, but the direction of the growth. Of course, in growing patient, you have to deal with the growth. And in adult patients, they don't have growth. So the only thing that you have to do is to rotate the mandible downward and backward by using that bi-razor. So suppose in adult patient, it would be easier than you use that in growing patients. So this is one of the example, 31 years old female patient. This is my recent patient. So I started with my recent patient. So you can look at that when she smiles, because the lower incisor covers the upper incisor. So when she smiles, you only see her lower anterior teeth. And you can see class 3 anterior cord spine, upper and lower anterior myocardium. So what are you going to do for this patient? So what I did was, right at the beginning, actually I put on the bi-razor already. And I think the patient decided to use this bracket because the color, and that is quite smooth. There's no sharp angle. And also because the hook is much smaller than the others, the patient feels much more comfort with this bracket. So, and also, when I finish the patient, it's easier to remove the bracket. So 3 months, lower I put tails because the lower lip and the lower incisor, I want to bring the lower dentition back with tails on both sides, and I kept going for using the bi-razor and the intermediate elastic. Since when I'm using bi-razor, the upper teeth gotta have open bite. So I would like to bring the upper teeth and lower teeth bite together with that intermediary elastics. So 3 months, you can see the improvement of the chin projection and also the upper incisor display. Once you open the bite, then the upper incisor will be seen, because before it will be covered by the lower incisor. So you can see immediately after you put the bi-razor, the patient smile, the upper incisor display will be much better. 1 year and 2 months, I also put on the upper as well, because when I rotate the mandible, at the same time, the lower incisor also was brought backward as well. So I also have to bring the upper dentition back. And also over here, you can see I put lower intrusive labrum to intrude the lower incisor, because I would like to hide the lower anterior teeth as good as possible. And also when I do total arch distalization, the upper incisor will tip lingually and extrude the front. So I don't want to do upper incisor intrusion. It's good to have an extrusion for this case. So 1 year and 2 months, you can see her facial profile was improving now. 1 year and five months, because the lower right taste dislodged. So I have to apply class 2 elastic to bring also the upper dentition back and lower dentition back at the same time. 1 year and 5 months, you can see that. 23 months. So you can see this is a repeat protocol. I will keep using bi-razor until I see a stable result. So recently, I just prepared to remove the bracket. So that is the latest photo of this patient, the change of her facial profile. You can see that there's no tooth extraction, no surgery. What I did was test, bi-razor, intermediate elastic, that's it. So let me get more into detail by using this previous patient that I treated before. 22 years old female patient, the chin complaint was underbite, big chin, and crooked chin as well. You may see also actually her chin deviate to the right side, and also she got a TM joint clicking when she opened her mouth. So here you can see the facial symmetry, and again, Most of the class 3 patients, when they smile, lower anterior teeth showing instead of upper. So that also is a problem that we have to solve. CT scan showing class 3 major hyperplasia, mandibular prognathodon, and chin deviate to the right side 2.5 millimeter. Class 3 buccal occlusion, anterior crossbite, crowding, and lower denominator off to the right because the chin deviate to the right side. So right at the beginning, as you can see, once I bond it, maybe in the second month or third month, that you can immediately put on the biracer. Once you put on the biracer, you can see now the canine became class 1 because you move the jawbone, you rotate the jawbone backwards. And denominator not on yet. You can see only 1 month. It looks like she had a surgery, the face, the lips, the smile. It looks like she changed to another person by only using biracer. Although this is not true. The true thing is you have to use the intermaxillary elastic to build up an occlusion that can hold the mandible there. So I keep going for that. So 6 months, the lower, I put a taste to help to improve the anterior crossbite. Now you can see the canine is getting class 1, and the bite is getting settled as well. You keep going for that, and here the next step. Because I would like to increase the upper incisor display as good as possible, so I put 2 tastes in upper between 3 and 4. And I use a extruding spring. I make it from 17 by 25 TMA wire, so I can extrude anterior teeth and also extrude posterior teeth as well. And not only help to increase the upper incisor display, also you bring the upper occlusal plane down and also push the mandible rotate downward and backwards. 11 months. Now, at this moment, the lower denominator was on. And I removed the biracer to see whether the result is stable or not. Of course, the result is not stable. So I kept going for that for several times. So I keep the same mechanism, upper total arch extrusion, biracer, and intermaxillary elastics. 28 months. I removed the extruded spring and also removed the biracer, try to see whether that is stable or not. Of course, you can get the result quickly. Around 6 months, you'll be able to get a good occlusion and good profile. But you are right, everything have relapse. You cannot have relapse. The rest of the treatment will be spending time on dealing with the relapse. The best policy to deal with the relapse is to against it. No, you have to deal with the relapse during the treatment instead of after treatment. After treatment, you only have retained the how could you deal with the relapse, especially jawbone. So you can see the progress change of her face. You can see actually the result, the improvement of her face actually was there 6 months already. The rest of the time, you can see some relapse. Don't worry about that. Keep doing for the same mechanism until you see a stable result lasting for 4 to 5 months. Then that is the time to finish the patient. So overall, I spent 33 months. You said that was a long term, yes. But in comparison to the price, to the process that we went through for the surgery, I think that is worthy. The change of her profile and smile, I think that was nice. And also look at the upper incisor display, because we purposely bring the upper dentition down. The change of the soft tissue by superimposition looks like she had a surgery. because chin and lower lip just went backwards. And superimposed, you can see upper dentition was actually for 4 to 6 millimeter. The mandible, the lower dentition, posterior extrusion, lower anterior intrusion. And you can see the change, positional change of the mandible. Went backward for 7 millimeter. So it looks like the mandible was surgically set back for 7 millimeter, but no, actually no. And of course, we also care about whether the contact position has some changes. You can see now the left side contact actually have a little bit upward reposition during the process. And that was the reason why you can see this patient. I think I can go back. You can see this patient, the chin deviation actually improved. That means the birazor may also can improve the chin deviation as well. And one of the reasons is, this is so. One of the reasons is the contact repositioning on the left side. So left side, the upward repositioning so the chin will move to the left side. So left side contact you can see here. Also from the frontal view, you can see there's an upward repositioning of the contact head on the left side. So you can see the shift of the mandible as well. This is another patient, 21 years old, underbites, crooked face, long chin, but again, asking for nose gel surgery. Intraorally, you see class 3 anterior cord spike, upper and lower anterior crowding. So right at the beginning, you can see right at the beginning, after bonding, when the patient adjusts well, then you can start to put the birazor, raise the bite, and then apply for the intermediary elastic. And also lower taste actually was there to help to bring the low dentition back. The change of patient face. Once you put out the birazor, the face change. And patient, they can see it. So they will be very happy to wear the intermediary elastic because they see their face changes very quickly and quite nice. 5 months, upper taste with extruding labor arm to increase the upper incisor display. 13 months, keep going for the same procedure. And this moment, you can see now the dental midline on. Actually, I did nothing. I did nothing for change the dental midline. But since the birazor, I said that earlier, that working as a single tooth occlusal spring. So that helped to relocate the contact hair. 13 months, you can see the change of the profile. 28 months. So you can see, actually the result is quite early there already. But I just kept going because I want to see a stable result before I remove the bracket. 13 months. So I removed the spring, removed the birazor, but keep using the intermediary elastic when you are observing whether that is stable or not. 35 months, finish the patient. You can see the upper incisor angle, lower incisor angle. Without tooth extraction, usually you will see procline the upper incisor, retrocline the lower incisor. But pay attention and look at the upper incisor angle and lower incisor angle. When she smiles, full upper incisor display. Good facial profile and also the lip thickness maintained quite well. The progress change of her facial profile. You can see the result actually is there quite early. The rest of the time, we have to keep it stable. The progressive change of the chin deviation. So also the chin deviation can be improved by using the birazor. The upper incisor display is not quite nice. So actually, if you look at this, if I claim, say this is a surgical case, you will believe. But anyway, there's no jaw surgery. So we did a study to look at what are the average change of this kind of treatment. So we have a CT scan, overall superimposed on the cranial base to look at the change of the mandibular posture, position at the menton, Pogonian, and etc. Superimposed on the cranial base to see the changes of the maxillary dentition. Mandibular superimposed to see the changes of the mandibular dentition. So the overall, you can see for those group with birazor, at the beginning, actually, they are more severe patients. The reason why they went for birazor because they were more severe than those patients without. And also, you can see the facial convexity, extra things, they were all significant difference. Although, I'm sorry, the improvement of the facial convexity actually was much better. Although the treatment duration was similar, okay, that is the change of the birazor group had the more maxillary total arch extrusion and also have more downward and backward of the mandibular posture change. That means the mandible actually went downward and went backward. The backward movement is around 2 millimeters. And of course, when you are extruding the upper molar and lower molar more, the mandible rotate will be more, so that the chin will go back more. So conclusion will be orthodontic total arch extrusion technique with birazor and intermaxillary elastic improve the skeleton facial convexity in adult patient with class 3 malocclusion through backward and downward rotation of the mandible. And don't forget, this technique, of course, can be used for the relapse in surgical patients. In class 3 patients, if they go for surgery, certainly they're going to have certain degree of relapse. When you see the relapse in surgical patients, use birazor to rotate the mandible back. So that would be a very good another choice for surgical patients as well, not only for non-surgical patients. So I give you this patient, 47 years old. I think her face, I would say, looks like older than her age, to be honest. So you can see her upper lip thickness is not good. The upper incisor display is not good. Too much lower incisor display, and the chin and the chin projection is a little bit more than the others. Anterior crossbite. Multiple missing teeth, have a right side TM joint clicking, lower dental minor is on. So again, 2 months of the alignment, I put on the birazor already. And of course, the lower dental minor still shift to the left 1.5 millimeter. In 2 months, you can see the face already changed already. So patient, they will be very happy because shortly after the start of the treatment, their face improved. Once their face improved, their cooperation will be very good. 3 months lower test to help to bring the low dentition back. 5 months, 1 year. So I keep going for the same mechanism. But the lower left side taste dislodged, okay, but the denominator is on already. 1 year. The further improvement of a younger facial profile, but anyway, patients, she still prefer a little bit slight face, especially the upper and lower lip. So she was asking, hey, I want my lip back more. But then I say, well, if I bring your teeth back, your nasolabial fold will become deeper, your lip may become thinner, which gives you an older facial appearances. But she still insisted, say she preferred to have a lip back more. So we put the test back again and keep retracting the upper and lower dentition. 1 year and 9 months. Okay. In the lower, of course, we have to try to into lower. And here we use a taste to into lower incisor because I want to hide the lower anterior teeth as good as possible, show the upper dentition as good as possible. I spent 3 years to finish this patient. Okay, and let's look at the face. This is pre-treatment, 1 year of treatment, 3 years of treatment. You can see the progress change of her face, and I feel like she get younger after the treatment. Okay, that is better upper inside the display and less lower inside the display after treatment. Okay, so you can see after I retract the upper and lower lip, actually the chin projection looks like more. So we have to be very careful when we only retract the lower entities or upper entities. This might give the patient the chin projection worse. So we do have a study to look at the change of the lip thickness after treatment. So we measure the upper lip area, surface area, and lower lip surface area. The results showing that the upper lip surface actually, for those patients who had birazor, increased a lot. That means when the upper lip thickness becomes thicker, the patient look younger. When the upper lip becomes thinner, the patient look older. So we have to be careful about not only the lip, the position of the lip, but also the thickness of the lip. And don't forget, we orthodontics, we are able to control the lip thickness by positioning the teeth. So next, I will get into how we can really control and correct or improve the chin deviation. For chin deviation, that could be because of size difference between right and left. Could be because of morphology difference between right and left. Could be because of joint, the TM joint. The mandible could be quite symmetrical, but because of joint displacement, so that the joint deviates to the other side. Or, of course, we know that could be because of occlusion. Okay, so recent year, we haven't seen this a lot. A lot of TM joint specialists, they say when the facial asymmetry patient, they have occlusal spring, and after that, their chin deviation, facial asymmetry improved. And this has been studied and reported in several articles. So the problem is how we treated that, the joint, occlusal spring. But the question would be, if we use occlusal spring to treat a facial asymmetry, then we are not able to move teeth. So my idea is to shrink a full coverage occlusal spring to a single tooth only, so that I can move the other teeth. So that would be the same concept. Occlusal spring is to establish a stable occlusion to stabilize the condyle. So again, no matter that is a full coverage or not, single tooth can also open the joint, and then we do tooth movement to establish a stable occlusion to stabilize the condyle head. So that is the whole concept why we are able to use that. So this is single tooth occlusal spring, also called birazor. My hypothesis to using this birazor is the single tooth occlusal spring open the joint space and repositions condyle and then induce up and down roll rotation of the mandible. Okay? And then I also have another design that is by slope. That is a slope in upper and another slope in the lower, and they are opposite. So when the patient they bites, these two slope will guide the mandible to the direction that you want. Okay? So my hypothesis for this bi-slope will be they're going to induce a yaw rotation of the mandible, because some of the facial asymmetry could be because raw rotation, some of them could be because of yaw rotation, and some of them may be a combination of raw rotation and yaw rotation as well. So I would like to apply these to improve the patient's facial asymmetry if the patient have a condylar displacement. So let me use this class 1 case as an example to show you how we can utilize that. So first of all, we would like to know why the mandible deviated. The occlusion is quite nice, although she had the braces before, but she wasn't happy about the face. It's not symmetrical. So from the CT scan, you can see chin deviate to the left side. And when I analyze the length of the ramus, actually the right side and left side, they are in similar lengths. Because in most of the situations, we believe that it's a jawbone size discrepancy caused the facial asymmetry, but no, this is not 100%. There are many patients out there, their ramus height actually are quite similar, but had a chin deviation. So that could be have something else that caused that much of the chin deviation. So second one, I want to see the body length and also the morphology and geometry of the mandible. Although the geometry, there's a little bit asymmetry, but basically the length of the body, they are equal. That's supposed not to give a 5 millimeter of the chin deviation. And then I look at the condylar position. Now look at the position of the mandible. You can see there's a yaw rotation. There's a to the left yaw rotation. So you can see to the right, no, to the left, I'm sorry. So you can see the right side condylar actually displays backward and inward. The left side condylar actually displays forward and laterally. Okay, because she also have clicking. So this is a very good sign that part of the chin deviation in this patient was because of the condylar displacement in this patient, especially yaw rotation. Look at this. The joint space of the left side actually is more at the back. So that shows that the condylar head actually displays anteriorly. So if we were able to do another way of yaw rotation to reposition the condylar head, then what we will be able to improve the chin deviation without surgery. So put on the wire, and then for the upper occlusal can, I will use the yin wire. So that is the yin wire she needs. Okay, and looks like this. That is the yin wire. I use that to improve the occlusal cant. So and then at the same time using bi-slope, because her main problem of the facial asymmetry was because of cant and also the mandibular yaw rotation. So when I use these two bi-slope to rotate the mandible. Then also don't forget the intermediate elastic. So just keep on that. And after that, at this moment, I started to use the yin wire. And then, of course, you have to observe whether the result is stable or not. Make sure that the result can be there for 4 to 5 months before you remove the bracket. But actually, in this case, I did not. So you can see the changes of her face, and the chin deviation improved after the treatment. This is quite bothering. Okay. So summary of her treatment, she had a yin wire for 8 months, and also bi-slope for another 8 months. But here, since we could not very sure that whether the patient only have yaw rotation without raw rotation. So I would strongly suggest you start from bi-razor to have a raw and to have a raw rotation first, and then if the chin deviation stop improving, and then you can change it to the bi-slope, have a yield rotation of the mandible. So that is her CT scan. You can see the changes of her mandible. The move to the right 3 millimeter. And you can see, from the segmental view, you can see there's a yield rotation of the mandible. The right side contact actually repositioned 1 millimeter posteriorly. And the right side contact had also repositioned 1 millimeter to the right. That helped to improve the chin deviation. And I superimpose on the mandible to see whether there's a surface remodeling going on. So you can see there's a favorable contact surface, superior surface deposition, remodeling 2 to 2.5 millimeter on the left side, 1 millimeter on the right side. That means that also helped to improve the chin deviation. 3 years after treatment, the result remains stable. After treatment and 3 years after treatment, I think the chin deviation remains stable. The occlusion remains stable as well. So I took a CT scan, again, 3 years after treatment, to see why the chin is stable. So when I superimpose them, you can see on her left side, you can see green color ramus, right? That means green color is 3 years after treatment. That means after 3 years after treatment, the left side actually moved forward. The left ramus actually moved forward. Think about that, the left side ramus moved forward. That helped further improve the chin deviation in this patient. So superimpose on the mandible to see whether there's a surface remodeling. I found out there's unfavorable condylar surface remodeling happening. More left side condylar reposition remodeling 2 millimeter, then the right side condylar surface remodeling for 1 millimeter. And suppose to have relapse, but she did not have relapse. And this is to see the positional change of the mandible. You can see there's a favorable condylar ramus repositioning happening. So you can see from here, from here you can see the left side condyle actually reposition further forward. And that helped to maintain the result. So we have started to look at the effect of those patients. So the patient for the experimental group, 13 of them, they have, thank you very much. Yes, okay. 13 of them, they have a TM joint problem. So today, you will learn that if you go back to your office, you see your patient have a TM joint clicking problem. For those patients, you may be able to improve their facial symmetry, because that means clicking means condylar displacement. So we have it over superimposed, we have a regional superimposed to see the changes. And you can see for the deviated side, you can see there was a more inferior and anterior displacement of the mandible, of the condyle, I'm sorry. That means the deviated side had more inferior anterior reposition that helped to improve the chin deviation. So look at the surface remodeling. That is the methodology that we use to look at the surface remodeling. Very surprisingly, both of the group, they both have condylar surface remodeling. You can see intra-group, you can see a lot of significant difference, but intergroup, there has no significant difference. That means no matter the patient have a bi-razor or not, they always have a contact surface remodeling, even though only have the braces. So don't forget, when you put on braces, when we move teeth, usually we'll have contact surface remodeling happening. And also look at the granule fossa remodeling. So that is the methodology that we use to look at the granule fossa remodeling. And there's no significant difference of the granule fossa. So contact is easier to have surface remodeling, but not the granule fossa. So look at the rotation of the mandible. So you can see most of the time the mandible have roll rotation and also have a yaw rotation. That means the deviated condyle move down and forward. So that induces a roll rotation. When you move down, there's a roll rotation. When they move forward, there's a yaw rotation. So that was the reason why those mandibles can be improved. And we also look at the improvement of the chin deviation. So overall, you can see 1.8 millimeter of improvement. That's around 2 millimeter easier to remember. That means in average, if we use this technique, we'll be able to improve around 2 millimeter of the chin deviation. So now here comes the first clinical implication. Since the chin deviation, in average, we are able to improve 2 millimeter. And second thing is because of chin deviation less than 2 millimeter is hardly can be seen by the patients. For example, if I have a chin deviation around 3 millimeter, of course you will see it. And I am able to improve that, reduce that for 2 millimeter. That means I will only have 1 millimeter left. The patient, they won't see. Maybe you will not see neither. So that is the reason why you can tell the improvement, because within 2 millimeter, the patient will hardly to be seen. So overall, they are 4 millimeter. So for chin deviation, less than 4 millimeter, that means we have a chance to improve their facial symmetry without surgery. So don't forget, those patients of mine, they all have a T&D problem. So the second clinical implication will be, if the facial symmetry is because of jawbone size discrepancy, is because of morphology, that means you have less chance to improve that without surgery. If the etiology is because of occlusion, because of joint, then we have a higher chance to improve the facial symmetry. So conclusion of this study, the impact of the bi-razor slope on non-surgical orthodontic for mandibular symmetry could be due to a favorable repositioning of the condyle on the deviated side and then mandibular roll or yaw rotation. Of course, this technique, non-surgical orthodontic treatment with or without bi-razor, don't forget, once you put on brackets, the condyle start to remodeling. So the question will be, how should we maintain the result? You see, we have a teeth retainer, right? We have a Holly retainer, we have an SS retainer, we have bonded retainer to retain the teeth. But how could we retain condyle? Does condyle has a retainer? The answer is yes. The condyle has a retainer. Let me show you this case. This is a 49-year-old patient with a facial symmetry, class 3. I'll go quickly. She had a tooth movement before, and the plan was gonna do upper taste to do thoracic extrusion to increase the upper incisor display, lower taste to do thoracic digitalization, bi-slope and bi-razor for joint and symmetry, put on the brackets, lower taste, and then bi-razor on. Okay, then I'll keep going for that. I will go quickly. Upper taste, actually upper dentition, and then now I change it to bi-slope because it had been 10 months. Her facial symmetry improved a little bit, but not too much. So now I'm using bi-slope to bring the denominator on to have a yaw rotation. Compared to the change of the face, 21 months, okay? So until now, I still feel good. But the problem comes after this. This profile was nice, 33 months. You see, from 21 months to 33 months. Why is that? Because I keep having relapse. The chin keeps relapsing back. So you can see little by little, the low denominator off to the left side. 0.5 millimeter face, you can see a little bit of chin deviation now. 36 months. You see the low denominator further off to the left side, 1.5 millimeter. But because of 36 months already, and I asked the patient, should we keep going or not? She said, no, enough. That's finished. So I finished her at 37 months. But you can see denominator was not on, and the face still have a little bit of chin deviation. But in comparison to before, I think that was a good improvement, although not perfect, but could be quite acceptable. And the CT scan, okay, you can see the left side condyle, I did a good job to have an inferior repositioning of the left side condyle. But 1.5 years after, she came back to me and had a further denominator off, and she was complaining of TM joint clicking, TM joint pain. She was complaining about the chin deviates again. So she was like this. Okay, so what are you gonna do? So before I make the decision, I took the CT scan and said, okay, I'm gonna take the CT scan. I'm gonna make sure that what happened then before we can go further. So that is CT scan showing that, yes, the mandible shifted back to the left a little bit. And when I have a comparison of after treatment and 1.5 years after, you can see obviously the right side condyle have an inferior and anterior displacement. Okay? The left side condyle have no obvious displacement. So here I know that the problem is on the right side condyle, head. Okay? And in terms of pitch, class 3, they have a little bit of relapse, which is acceptable. Okay? So the question will be, could we reposition the right side condyle head back so that I can put the chin back? So again, when we reposition the condyle, what we're gonna do is occlusal spring. Okay, so either I can send my patient to a TM joint specialist to ask the TM specialist to have a occlusal spring for her. Or because I'm an orthodontics, are we able to give her something very similar to occlusal spring? The answer is yes. So you can see the design is this SS retainer. I have a resin, bi-razor inside to open up the joint again, or I can put bi-razors on holy retainer to open up the joint. So the answer for what is the retainer for condyle? Occlusal spring or bi-razors. Oh, I'm sorry. So this is immediately, when I put on the SS retainer with bi-razor, you can see immediately I put it on, only in upper. Okay, I asked the patient to wear this when she sleeps. So once I put it on, I ask her to bite. When she bites, you can see the denominator almost on. The clicking gone. And then she was happy. I have an appointment with her 3 months after. She didn't come back. So I asked my assistant, call her, ask her to come back. And she answered, I'm okay now. I'm quite happy with that retainer. And I'm a teacher, I don't have time to go back. When I have problem, I will go back. Until now, she haven't come back yet. Okay, so take-home message: apply biorazor and intermesh elastic for the intermediate class 3 profile improvement in the beginning of the treatment or as early as possible. The current practical line is a clinical chin deviation within 4 millimeters could be possibly improved by non-surgically by using biorazor or bi-slope. Removable retainers with biorazor could be a good option for retaining the contact repositioning in class 3 or mandibular symmetry patients. These is all the messages that I would like to, that you have. And I hope these messages can help your practice and also can help you out in some of your trouble cases. Thank you very much.
Thank you, Dr. Eric Liou. It was a great lecture from you, and you have really expanded the horizon of orthodontics, especially you have gone into the surgical orthodontics. So we put on record your all efforts in the science of orthodontics. Thank you very much. Please come to receive the certificate of appreciation from Indian Orthodontic Society.
Thank you. Thank you. Thank you.
It was really a great work done by you.
Thank you.
Nishi. So we'll now be having an interactive session led by OrthoFX. Now I call upon Dr.
Luskar are chairing the session for Dr. Madhur Upadhya, the keynote speaker of today. Dr. Madhur Upadhya is Professor and Director, Center of Orthodontic Care at University of Connecticut Health. He is also a Director of Orthodontic Fellowship Program and a Diplomat of American Board of Orthodontics, ABO. His primary research interest is in biomechanics of tooth movement. He routinely conducts detailed courses and workshops on biomechanics in orthodontics at various universities in US and abroad. He has published over 100 scientific papers and a book, chapters and abstract in national and international journals. He's also been recipient of foundation and industrial grants. His current research focuses on application of finite element modeling and artificial intelligence, machine learning in orthodontics, where he has multiple publications, grants, and holds US patents. He's on the editorial board of various orthodontic journals like AJDO, Angle Orthodontics, European Journal of Orthodontics, etc. In his spare time, he loves to play and follow tennis. He has keen interest in physical sciences, especially astronomy as well. So, ladies and gentlemen, I present Dr. Madhur Upadhya.
Thank you. Thank you. Thank you for the great introduction, Anand. Whenever I hear such nice words about myself, I get excited to hear myself. So, good afternoon, everyone, and thank you for your patience. I know I'm the last man standing between you and getting out of this hall. So, hopefully, I'll make it worthwhile for those who have stayed. This is the pyramid of appliance efficiency. As you go higher up in this pyramid, the appliance systems offer you more versatility, more options to treat various different kinds of malocclusions. Retainers or aligners can move the teeth a little bit here or there, can carry out some specific types of tooth movement. You need arch wires and brackets to create more complicated three-dimensional tooth movements. And to those arch wires and brackets, if you add like power arms, hooks, push coils, like build over on it, you create some complex systems that has more versatility. And then finally, at the top comes so-called exotic systems. Systems which incorporates maybe TADs, surgeries, power hooks, e-chains. I call them exotic. I love those exotic systems, or at least my former self loved it a lot. And did I make a life out of it? I did. Numerous articles, publications, workshops, courses, and it was all great. But the current me, or from the past few years, I've become more nuanced. Because what I've noticed is that as you go up the pyramid, you also encounter another phenomenon called entropy. Or, from the second law of thermodynamics, a system, the more complicated you make it, the more is the tendency for it to go in a state of disorder. That means the higher you are, if you consider the top system, if one or two things do not work according to how you have planned it, the whole system fails. So what I learned was that you need efficiency, but you need to respect the entropy too. So there's a fine line, and you need to strike the balance to get the maximum efficiency out of your appliance systems. How do you do that? But what I discovered was you need to understand the first principles. So the question is, what are first principles? Well, first principles is a way of thinking where you boil down any problem or situation into some basic elements. Those elements are grounded to science, physics to some extent, and they cannot be further broken down. And you build it up from there. For example, we all can cook in some capacities. Like normally we catch a recipe here, our mom or grandmom taught us something, or we watch something on YouTube, and we make something out of it. But a chef knows how all the ingredients work, what temperature the cooking should be at, how to change dishes according to the season, how to create new stuff. That's first principles. For humanity to conquer space, scientists need to understand the first principles of rocket science. Laws of motion, how gravity works, fuels, combustion ratios to liftoff. That's when rockets are going to work. Historically, famous and not so famous people have relied on first principles to do some fantastic job. In orthodontics too, first principles can be deployed to solve and understand a lot of controversies which perhaps all of us are familiar with. So these first principles at University of Connecticut, when I teach them, I take about 40 hours to cover that. At some of the schools where I'm invited, I take about 2 to 3 days to go over all these first principles. At some other places, just a day. But out here, I need to do it in just 40 minutes. We all are in a hurry, right? So what I'm going to do is that to make life easy for all of us, I'm going to boil it down into just 4 clinical scenarios. Make it simple, right? So starting with it, number 1. Here is a patient, regular class 2 patient. It was a growing patient, a young kid. When I look at a class 2, or when I looked at it when I was like that, way back, I used to say, all right, class 2 patient, we'll grow the mandible, we'll fix it, non-extraction, of course. So you give a twin block or any kind of functional appliance, move the lower jaw forward, create a class 1 and molar canine, 2 years of treatment, nicely done. Look at the patient before and after treatment. Yeah, I did grow the jaw. I used to feel elated seeing that. The superimpositions do corroborate from what on what I'm saying. The jaw did grow forward. However, when I did a number of similar patients over the years, and when they came back to me and I observed them, 2 questions came to my mind. First, when I finished the treatment, going forward, did the mandible relapse? Maybe, maybe not. Not sure. Controversial. But the second question is more pertinent. Well, the jaw grew, maybe, fine. But I had no contribution in growing his overall face, his ears, his nose, the maturity he got. I didn't do anything. How did that happen? Well, the thought that comes to my mind is maybe I was at the right place at the right time. Did I grow the jaw? Let's find out. So the question is, or the right question to ask is, does the mandible grow more in patients treated with functional appliances? Well, the best sources go to the literature. There are tons and tons of papers on it. And what I'll do is I'll bring out a systematic review because it encompasses all the paper. This was a systematic review published by a very solid group in functional appliances. They analyzed about 700 papers. Out of that, about 20 are clinical trials, and 4 are very high-quality RCTs. NIH in America spent millions of dollars to answer this question. And their conclusion was, there is no clinically supplementary growth of the mandible with functional appliances. So, jaw orthopedics in orthodontics, does it really happen? Because we have headgears and chin cups, face masks. Maybe they work. Do headgears restrict maxillary growth? Well, we can follow the same process, right? These have been there for hundreds of years, 100 years at least. So more than 800 papers have been published so far. And if we just summarize all of them through systematic reviews, to boil it down, this is their conclusion, broadly speaking. Headgears do displace the maxilla posteriorly. It does improve the AP relationship, and it can be a viable treatment for maxillary prognathism. Great. However, these conclusions, always in these systematic reviews, come with a disclaimer. What's the disclaimer? The evidence is of low quality. These results should be, please, viewed with caution. And this is always, forever, the line. More studies are required. So let's look at the numbers from these studies. Again, the summary. Average force is about 500 grams from a headgear. The SNA goes back about a degree. The palatal plane tips, as expected. The upper incisors moves back by about 2 to 3 millimeters, so you can understand where the majority is coming from, the correction. And finally, there are no changes in the AP position of the mandible. How about the face mask? Do face masks increase maxillary growth? Again, Dr. Sumit Yadav went over some of the things yesterday about class 3 patients. About 600 papers, maybe more now, by now. Here's the summary again. The average force is about 500 to 600 grams. What happens to SNA? It comes forward by about 1.7. SNB goes back by 1.2, which is expected, right? Because the mandibular plane is going to rotate down and back, which it does, about 2 degrees. And what happens dentoalveolarly? 2 to 3 millimeters of incisors proclining forward. You're getting the drift. So if you have a patient, broadly speaking, and you claim you have fixed the class 2 or class 3 completely, most likely 15 to 20% of that is skeletal, and the majority is dental. But this is just short term. How about if we pile up long-term results, which again, Dr. Yadav did yesterday? Long-term is interesting. Short-term, we know, minimum skeletal benefits. Long-term, there's almost a complete skeletal relapse. So you're basically left with dental compensation. So then there's a problem, right? The American Journal of Orthodontics maybe should be renamed as just American Journal of Orthodontics. The orthopedics doesn't make that sense. But on a serious note, why Does jaw orthopedic does not work? What's going on? Well, let's look at the first principles. Right? So the first principles are, for the jaws to move, you need a force. The force should act for a required number of time. And when the top two happen adequately, you get a biological reaction in the bone, and it should be a strain-based reaction, right? Because bone is tension-adapted tissue. You create tension, bone forms. So there has to be strain in the bone. Again, we as orthodontists are in a hurry. So I will summarize the literature by quoting this famous orthopedist and surgeon, Harold M. Frost. He's perhaps one of the most prolific orthopedicians so far. Lots of papers. His lab has probably got lots of awards. He has given all these famous theories, remodeling, bone modeling, and he was invited to write 2 papers for our profession, and he honored that request, and he wrote these 2 papers. So in summary, what he said was, you have to create microstrain in the bone, right, to grow it. So he said, just to maintain bone, you need about 50 to 1,500 microstrain. To grow bone, greater than 2,000 microstrains you need. Some of our great researchers in our profession started measuring how much strain we are creating with these devices. There were finite element studies and even a little bit more biological studies. A name that comes to my mind is Christoph Hallberg. He did a lot of studies on measuring the strain. Now, what did he and others find? Remember, to build bone, you need that much on the top left. So imagine you're applying 3 newtons of force, which, by the way, is about 300 grams. You just multiply it by 100. The amount of microstrains you get at the dentoalveolar level is 170. When you go further up, the strain dramatically reduces. It goes to about 10. So they said, this is not enough. Let's increase the force. They went to 5 newtons. The strain remained barely at 20 microstrains. They said, not good enough. Let's go further up. 10 newtons. That's about 1 kilogram of force on the face. That's a lot. And what they got was 50 microstrains. In their paper, they have concluded very clearly that we are far below of what we actually need to create meaningful change. How far below we are? We need 20. We need 2,000. We are at 20. 100x is the difference. So it's orders of magnitude short of what we need. And by the way, I'm not even here mentioning, is the force through the center of resistance or away from it? And what happens when the strain dies off? There is something called as disuse that takes effect. It's similar to you go into the gym, you build up bones and muscles, you stop going to the gym, what happens? Same effect. You take away the appliance, what happens over the long term? Number 2 scenario. I'll go to something more clinical, like more what we do day and day. Anchorage. Big topic. A lot of great lectures on anchorage. The problem is absolute anchorage. And a lot of literature has been published how to maintain this absolute anchorage. And we have been provided with various techniques and appliances. But at the absolute anchorage level, most of them fail. Either they need compliance, or it causes discomfort, there's a surgical step involved, or it takes too much amount of chair time. So they fail. But the question at the first principle level is, why do we get even anchor loss? Well, the same 3 features apply. On the molar, there's a force. When the force stays for a prolonged period of time, it creates a biological reaction, and the molar drifts forward. That's anchor loss. So what's the solution? Well, the young me thought, great, let's take away the force on the molar, right? You remove the force on the molar, there'll be no anchor loss. How do we do that? We use TADs. With TADs, you're not applying force on the molars, so there cannot be any anchorage loss. And as I said, we did a lot of work during those days on TADs. Did every kind of movement possible. On an average, a meta-analysis says It's beautifully conserved, 0.5 millimeters of anchorage loss. However, now we understand that if you're using tags, you are in the top part of the pyramid. You're in an exotic system. What else? There are other problems too, that some of the speakers have highlighted. There can be inflammation or irritation. There might be premature loosening. Screws get mobile. And there's a financial cost. Some areas, some practices have to bear the financial cost, or the patient has to pay it. So you got to deal with it at some level. So let's look at the anchorage loss problem. When there's a force on the molar, because the force is away from the center of resistance, it causes a mesial tip. We call it moment of force. What you see clinically is this molar tipping forward. That's anchor loss. So in the first, these two papers that came out some time ago, they reviewed over thousands of patients, and this is what they concluded, extraction patients. Upper first molars tend to be tipped mesially during orthodontic treatment. So your theory says mesial, research papers say mesial. Your first principle also should say tipping moment is one of the reasons you get anchor loss. So now that you have the first principle or the basic reasoning, what do you do clinically? You apply a counter moment, because that will take away the mesial tipping. That should fundamentally solve the problem. That's it. I'll show a case now to explain how we can apply that counter moment. Please, cases are just ideas. They do not prove or disapprove anything. They just present ideas to you. So here's a patient, full cusp class 2, molar and canine. We decided to extract the upper first premolars. That means the molar cannot go anywhere, absolute anchorage. The canine has to come full step back, 100%. So placed regular arch wires, started the regular canine retraction, except on top, there's an overlay wire called a cantilever spring made out of stainless steel that is going from the auxiliary tube and just sitting on the wire. And what you do there is you need to create that counter moment to prevent the molar. So you just put one bend. That will give you that counter moment. That should take care of the anchorage. Theoretically, it should. And it did. Not bonded the lowers, not bonded the second molars, did nothing. No class 2 elastics, right? Canine came all the way back. On the other side, same thing. Canine came all the way back. Molar stayed put. A comparison. Top is before, bottom is after. Molar you can see. In fact, if you can kind of keenly see, the molar is actually tipping back, which is great, right? You're kind of building anchorage, which is a very good sign to see in any case. And at that point, you can bond the lower, finish up the upper by retracting the incisors, and debond. So essentially, what did the cantilever do? Well, it utilized a simple first principle called differential moments, where what you're doing is you're just creating more moment on the molar. That's what it is. And you're getting good anchorage control. I'm not the first one to show this, by the way. Historically, there have been 3 or 4 papers on it. 3 of them prospective trials. And by the way, all of them showed, one by one, one showed 0.5, the other 0.4, one gained anchorage, and the other 0.6. These have been done by different authors, not related to each other, at different time points in the history. So there's no teamwork going on, and they all are coming to the same conclusion, which is remarkable. So we have the theory, we have evidence. That means we have created a secret sauce. And any case that comes, which is similar to what I showed, you just rinse and repeat the same recipe. So here's another patient, full cusp class 2 molar, canine. Again, upper bi, throw in the cantilever springs, start retracting the canine. There it goes. The other side, there it goes. And you can see the molar. You're gaining anchorage also, which is great again. Not only preserving, but gaining. Once the canines are back, you can bond the lower, retract the upper incisors, and debond. So So the question quite often I'm asked after seeing all these wires and cantilevers, which wire did you use? How much did you bend? What was the activation? What should I block? All that. Well, we did a bunch of research on this topic at UConn. It took 3 to 4 years to kind of figure all these things out. And what we did was that we compiled all of that research, all of the data into one simple app on the website. Okay? Scan this, go there, fill in what you want, and you get what you want. Okay? So this simple, you'll see when you use it. It's pretty straightforward. That's how the app looks like. All right. Clinical scenario number 3. This panoramic X-ray shows missing lateral incisors, congenitally missing. So the goal is to close the space. Why? Because this is the patient. Young kid, straight profile, nasolabial angle is flat. So we wanted to close the space. The mom wanted the space to be closed. Yeah. The only way if you can quickly figure it out is by moving all the back teeth forward. You cannot pull the front teeth back here. Okay? So the goal is full posterior protraction. What would I have done if I was 10 years before this time? I would have maybe used some TADs or something. But here, I wanted to just go without TADs. But if I do without TADs, I'm going to get this. Distal tipping of the front teeth. That's anchor loss. So I don't want to do that. My previous self would have done that. Used a palatal TAD, constructed a device, and start protracting everything forward. I don't want to do it now. Why? Because of this. Right? What if something breaks? It's a big headache. Change up things. I don't want that. I want more reliability here. So, going back to the first principles. Same thing, I have to counteract the tipping moment. I don't change anything. I apply the same principle to this situation. I need to create this counter moment. So the same patient, put the upper braces, consolidate the front teeth together, and now the time comes for controlling this anchor loss. How do I do it? I just place one bend again in the wire right there so that I create this moment. Of course, it's bilateral. And then you're just applying a chain from that canine to that premolar. The front teeth, of course, are together as a unit, and you start moving them one by one. Again, the bottom has not been bonded. No elastics. Nothing of that sort. I don't want compliance, another added problem. And you just keep on moving the teeth forward. A visit after visit, you're just changing the chain. That's it. Once one premolar goes back, you just shift the bend one step back, and you start moving the next premolar. Gradually, you move everything forward. You get some drift odontics also, which is great. And then the patient is done. It was complete molar protraction. The question comes again to me. Which wire was that? How much was the bend? What activation? Where do you place the bend? Degrees, all that. Again, some beautiful collaborators at UConn. We did this study, number of studies actually, and they are there in these articles. We used 3D sensors to quantify exactly the force system. And all these data that we got, because we've tested every wire combination, every possible bend, every location of the bend, is compiled again in this app. So once again, we have the first principle, we have the theory, we have the app, we have the cases, we have established the secret sauce or recipe. Future cases, just rinse and repeat. So here's another patient. This is adult now. And she has been treated by orthodontics, and she was told that, you know what, once you grow up, you can get implants and get your lateral incisors fixed. She's like, great. She goes to a dentist. Hey, I want now implants. He's like, here's the bill. She's like, oh my God, I didn't expect that. So she comes to us. Maybe somebody referred her to us, not sure. We said, okay, maybe we can do something, but do not bank on us. We're going to give it a shot. So same thing, as I showed before, consolidated the front two teeth, gave her some Pontics so that it looks aesthetic, and started moving the canines into the lateral incisor space. Same V-bend, nothing different from what I showed before. Once you move the lateral, you shift the bend back. Now you start moving the premolars. Same thing, one bend to create the counter moment. You move that, you can see the drift orthodontics that starts happening, which is the beauty of it. And gradually just go one by one, move everything forward. Just bonded the lower at this stage and finish up the case. It took about 28 months to 30 months. I'm not sure exactly on the timeline, but somewhere around that. And the patient was done. Extremely happy. Just recontoured the canines a little bit to look like laterals. And this is the patient before and after. Clinical scenario number 4. How about the lower? In the lower, if I want to protract that molar forward, I would put an E-chain to do it. What it's going to do, it's going to cause distal tipping or ankle loss. I'm going to create an overjet. Again, I don't want that. So what would have been my default method? TADS. As I said, I made a life out of it by doing this. However, TAD is doing this to me, right? Which is great. And as I said, we worked a lot in this topic, did a lot of crazy things to move molar forward with the TADs. But we now understand the problems that come with it. So we want to find a solution to get around this TADS problem and make it more predictable and reliable and still not lose the efficiency. There's one more problem with TADS that I have noticed. It's not that common in the literature too, but it's a very first principle problem. When you apply a TAD or a force vector like that, because the force vector is at an angle to the arch wire, it creates binding friction as you drag it forward. So what's going to happen? It's going to drag the whole dentition forward. There it goes. And you keep on doing it, you'll keep on dragging it forward. I'm not saying it happens all the time, but it happens quite a bit. So these are some of the situations that come with TADs. So let's go back to the drawing board. I don't want that distal tipping. Now we understand that means you need to create a counter moment. V-bends, maybe it works, but let's take a slightly different approach, which perhaps might be more reliable. The counter moment principle stays the same. I need that counter moment. So let's look at this patient to show the idea. Remember, just cases are good for ideas. Here's a patient missing incisor on the bottom. Profile is good, everything is great. We wanted to push all his back teeth forward into that space. That was the objective. So we want to align this and close up this space by moving the back teeth forward. So what we did, we used a fixed functional appliance. You can use any fixed functional appliances. You can even use a homegrown fixed functional appliance. Doesn't matter. The goal is that when you apply a chain on the front teeth to move the molar forward, the front teeth are going to come back, right? So you want to counteract this moment and force with a force from the forces or the functional appliance, which will create this counter moment because it's away from the center of resistance. So you see how the front part, everything cancels out. And what you're left with is a pure force on the molar to come forward. That's the idea, that's the principle. So this is how the patient went. The pan to show that I didn't mess up the roots and all that stuff, so everything looks very parallel and nice. And this is the patient after D-band. We did this some years ago, and we were surprised to notice that nobody had an idea to use the fixed functional appliance to do this kind of protraction, because we went through the literature. So we said, you know what, let's do some retention pictures, do the superimposition, which showed beautiful protraction, no changes in the mandibular plane and in the incisors, and then publish it. And so it did get published, because it was first of its kind, probably. So the technique works. So we tried another patient on it. This time, both sides are missing. The goal is to push both the motors forward. There you go. A lot of space on the bottom. Same thing. Any functional appliance, chain it. That's it. So every visit, you're just changing the chain. The molar moves forward, forward, Forward. Done. Again, superimpositions, lower incisors basically stayed there. Molars came all the way forward. Here the comparative pan, beautiful movement of the molars. Translation, very happy to see that. We did this. It took a while for us to finish this. Still nobody caught on to it. So we said, you know what, we'll write another paper. And we'll publish that too. And it got published, right? And then we were doing more and more such patients because we completely left TADs. We said, you know, this is a much easier way. Why bother? And nobody was publishing. We're like, what should we do now? Should we just keep on publishing case reports? That sounds... But anyway, as I said, we had the secret sauce, so we kept on doing cases after cases. And when we got a sizable amount of patients, so we said, you know what, cut on the case reports. Let's just do a research study on it. So this study came out just 4 to 5 months back, right? I think this was one of the good papers that I can say confidently we have written, right? Just good clinical stuff in it. I was not one of the evaluators in this. I kept myself out from evaluating this because I could have been easily biased towards one or the other. So it was done by blinded investigators, measuring all the data. In a nutshell, this is what they found. It is the conclusion of conclusions. 49 molar protraction sites were completed. Fixed functional appliance was almost twice as fast as TADS, and took significantly less time than TADS. I attribute it to the fact that with TADS, if something fails, the turnaround time is a lot, because you have to allow it to heal, and also the force vector is always off in a TAD, unless you want to complicate your device by putting a power arm and stuff like that. But remember, that will bring itself more liabilities. So overall, as I said before, first principles can answer fundamentally a lot of our problems, and then you can make solutions from those elements and build it up. Aligners is a very hot topic. A few years ago, we did write extensively on the first principles of aligner biomechanics. I didn't bring it up here at all because I didn't want to sound a broken tape, because I keep on talking about it at a number of places. This is a good paper, I think, to read. Dr. Venugopal showed the Dunning-Kruger effect, and I completely agree with it. Anytime any new technique or thing comes into the market, we all get very excited and we think we know everything about it, like customized aligners or whatever. That's really hot these days. But later on, we realize there's a lot more to learn. And we have to go through these repeated cycles of learning and unlearning. However, if we just deploy first principles right from day one and make our systems based on that, this learning curve is going to be way more smoother and even. With first principles, I'm not trying to tell you what you need to think. But with first principles, I'm trying to tell you how to think. And then you are your own master after that. Please remember, or I try to remember, biomechanics is the law. Everything around it is pure recommendation. Thank you for your attention.
Very nice presentation, Madhur. Breaking down the big problem into smaller segments and utilizing that in the clinical scenario. Thank you very much. I think as earlier speakers, we would take questions later, maybe during dinner or some other time.
Sure.
And some people have to go for AGM as well. Thanks a lot, sparing your time and sharing the knowledge.
Appreciate it.
It's always a pleasure to listen to you, Dr. Madhur. You made biomechanics so simple. You know, it's like always it's a learning. Whenever we hear you or read your articles, Thank you for your presentation.
I request the chairpersons to please give the certificates to the speaker.
Dr. Adith Venugopal is a specialist orthodontist currently working as a senior lecturer orthodontics in the Faculty of Dentistry at the University of Otago, New Zealand. He is also an adjunct associate professor and clinical instructor of orthodontics and dentofacial orthopedic at the University of Putistra, Phnom Penh, Cambodia. And he was previously into a private practice at Pancham Dental Hospital, Phnom Penh, where he practiced exclusive labial, lingual, and aligner therapy. He has completed his PhD in orthodontics from Yingpo National University, South Korea, under the eminent Professor Hee Moon Kyung. He has completed his clinical MS with an outstanding graduate award in orthodontics from the University of East Manila in the year 2014. He earned a bachelor's degree in BDS from Rajiv Gandhi University of Health Sciences, Karnataka, Bangalore. He has authored more than 100 publications in peer-reviewed international journals and published extensively in high-impact international journals. He has been invited keynote speaker at many orthodontic congresses and held courses and workshops on TAD-based biomechanics and all around the globe to reach high standards in clinical research and teaching skills. He's a contributing editor for Journal of Clinical Orthodontics, co-editor for Keenforth Orthopedy, and assistant editor for APO Strengths in Orthodontics. He is also on the editorial board of Orthotone, US-based orthodontic magazine, and he is currently the youngest fellow of two prestigious institutions, namely International College of Dentists and Perry Farchard Academy. He is also a fellow member of Royal College of Surgeons of England, Glasgow, and Edinburgh. Over to Dr. Adith Venugopal.
Good afternoon, ladies and gentlemen. Am I audible to all of you? Do I need to get louder? So I'm not going to introduce myself again, and I'm going to stick to 45 minutes. This is where my journey started. This is Cambodia. This is my parents, my wife, my kid, my other kid, that's a beagle. I've been inspired by Jim Waden and the late Herbert Klontz from the Tweed School. And towards the far left or the far right, you can see Professor Hee Moon Kyung. He was my PhD advisor. And in the middle, you see beautiful girls and a resident of mine who have helped me do whatever I do, and they brought me places. So now this, the first man standing next to me is Dr. Mauro Farella, because of whom I am right now in the University of Otago as a senior lecturer. And on the right, you see three gentlemen who know how to identify talent, I suppose. The first is Bjorn Ludwig, Nikolai Schwed, and Jay Bowman. I love these guys. I usually start all my lectures with this particular slide, which is the Dunning-Kruger effect. I want this lecture to be interactive, and I hope everybody knows this slide by now. You know, in the beginning, when I started off, immediately after residency, I believed I knew it all, and I believe everybody who has finished their postgrad think they know it all. So you have a very different kind of a confidence, don't you? You try everything. And then, one fine day, you start seeing that the lower incisors are proclining, the teeth are coming out of the bone, what you expect is not happening. And then you hit a low. That's your own confidence that falls low. And then with expertise, with time, some things need to just be organic. With time, you gain an experience which teaches you a lot more, and then finally you reach a new level of high, which is the true confidence, with experience. And that's what this shows. With that, I'm going to start today's lecture. Today's lecture is going to be on vertical control in all dimensions, especially to get pleasing aesthetic results. The first part of it is going to be the vertical control of molars in extraction cases. People usually don't start with their failures, but I like to move on from the failure and go to the good part. This was one of the very first bimaxillary protrusions that I had ever treated. She's a young girl, 24 years old. You can look at a class 3 profile bimaxillary protrusion with a lower space dentition. She came with a chief complaint of her profile. She did not like her profile. She said that I don't like my profile and I want straighter, better lips. How many of you would extract in this particular case? Can you raise your hand, please? I see just one hand raising. The question is correction of protrusion, not occlusion. So I think like probably Abhishek Ghosh thinks and a few others, I wanted to extract. I usually joke around saying that God has given premolars to extract. But in this case, I thought that definitely the premolars need to go for a good amount of retraction. And so I did. You can see a high-angled mandible, and you can see the protrusion as I mentioned. What I did was I placed 4 tads, extracted the premolars. I bent a loop within the arch itself because those days I did not have a crimpable hook to place. So I thought probably I could just bend a loop onto the wire and it's going to serve the same purpose. The lower tad failed for reasons I don't know, probably inflammation, probably wrong placement. It could have been anything. And I was successful in retracting and closing all the spaces. We know now that when you place a tad and you want to retract, what happens is basically an extrusive component on the incisors and an intrusive component on the molars because the forces are occlusal to the center of resistance. So now what happens is, in this particular case, I was expecting something of that happening. But then why did that not happen? And why did I end up with an even more longer anterior facial height? The reason is very clear in this particular slide. What happened is when I made the hook, I increased a lot of flexibility on the hook. So that kind of acted as a spring. And what that did, it did not keep the arch wire very rigid. It kind of bent the arch wire and gave a moment which also caused the tipping of the molars. The tipping of the molars, especially the upper molars, caused the premature contact and increase in the vertical dimension. And that was the reason why I made her face even longer. Now, I want you all to tell me, does the profile look better? I may say the profile looks better. But does the frontal picture look better? It doesn't look better because I've increased the lower facial height. And mind you, in a class 2 bimax profile, it's always kind of better to have a reduction in the lower anterior facial height by a counterclockwise rotation of the mandible. You don't want the mandible to elongate even further. And moreover, one thing that I had learned from this particular case is that you need to be very careful as to how much you retract in young adult girls. Over retraction causes lack of lip fullness, and that makes the patient or a young adult look old. I would say that now she looks at least 10 years older than when she started in just 1 year. So, I recommend everybody to have a read of this particular paper, The Facial and Dental Changes in Adulthood, which clearly says that the soft tissue draping of the upper anterior face increases in length in both sexes, whereas the female subjects, the lower anterior facial height decreases, but pogonion moves posteriorly. Lips become relatively more retrusive, while the nose prominence increases with the tip moving forward and downward. Now this is what happens as you age. And when you do this with orthodontic treatment, you prematurely age the patient. And you don't want that to happen. So I learned a lot from that particular case. I did. I made many more mistakes after that. But finally, what I did was I learned it the right way. Let's have a look at this particular case. She is a heavily protrusive case. She has a mild gummy smile. She has an increased lower facial height, as probably you could see. She does have flared lower incisors, extraction spaces on the molars, which have caused residual resorption. You can see some prosthesis on the upper arch. You also see mesially tipped and lingually tilted molars in this case. Now the worst part that you don't see here is the extremely high angled mandible. Now mind you, the incisor proclination of the lower incisors, especially over here, is not because they are really proclined, but the fact that the mandibular plane is so high that it feels that the IMP is really proclined. Now, obviously she needs good amount of retraction. And at the same time, how do you do this? Non-surgically, because this would be a surgical case. To top it all and to make it all the more complicated, we have a scissor bite on the terminal molars. Now this is the worst kind of case one can probably get, because scissor bites are the hardest kind of malocclusions that you want to treat, and you cannot do anything unless you treat a scissor bite first. You have to treat the scissor bite first before you move forward. Now imagine, if you've seen the previous slide, especially the one here, do you see the FMA? The FMA is 42.3, and probably for an Asian profile, the norms would be about 32, 33. And this is a 42.3, mind you, with a scissor bite. So what happens when we correct the scissor bite? The FMA probably jumps up to about a 50. Now, that's the main problem. But we need to treat it the way it is. She declined surgery, and the objectives were set. Correction of a lip profile, gain chin prominence, and reduce gummy smile. So, obviously, we had to raise the bite on one side because the other side was in a complete scissor bite. Raise the bite on both the arches. I used the buccal shelf tat, as you can see over here, and I swung the molars right out. Now, why did I use a buccal shelf and why didn't I use crossbite elastics? It's because crossbite elastics are going to extrude the molars on an already very high-angled mandible, which I don't want. But if I use a buccal shelf and swing the molars, what's going to happen is it's going to intrude and upright the molars, maintaining and kind of lessening the FMA. Now, once we corrected the scissor bite, you can see in the panel D, the residual open bite, which is the skeletal open bite, which should have manifested with such an open or increased mandibular plane. If you notice the overjet in this particular case, at this particular time, it's about, say, 8 or 9 millimeters. Now, the next objective is to gain her a chin. Now, you can't really do that if the mandible is small, but you can attempt to do that if the mandible is good sized and rotated downward and backward. So this was a case in which the mandible was rotated downward and backward, and so I decided that I'm going to rotate the occlusal plane, gain a counterclockwise rotation of the mandible, and give her a chin. I did not extract until I had intruded the upper arch and seen the limits of how much gain I would have gotten. So, intrusion has finished and extraction of the premolars have just been done. That's why the space hasn't closed. But one thing you would notice is the overjet has reduced by half already without me doing anything. Intrusion was done with IZC screws, that's infrazygomatic screws, and at the same time with a TPA, because she didn't want any more TADs. A TPA, I usually place it a little higher, a little lower rather, 7 millimeters of clearance. There is no evidence that that would particularly intrude the molars in any way. But anecdotally, I've definitely seen the tongue putting a lot of pressure, at least holding the molars where they are, if not intruding them. I definitely have seen the open bite close in a variety of cases with TPA placed low. Once that was done, there wasn't much left. It was just a question of retracting and correcting the bidental protrusion, which I did. By doing all these things, I forgot one very important thing, that was the gummy smile component of it. Because when you retract using incisors, remember I told you that you have an extrusive component on the incisors, which increase the gummy smile of this particular patient, right? So now I use an intrusion arch, which is a one-piece simple intrusion arch, tied it up between the central incisors so that the inclination would be in control. At the same time, I would intrude the incisors just a little bit. Like I do in most of the cases, I always end up with some kind of a gingival contouring because I like the finishes that happen after that. But in this particular cases, we had an aberration in the form of alveolar bone exhaustosis, which is something that we usually see in certain cases where we have a lot of retraction and intrusion happening. Now, the end was very simple. It was just finishing, and finally we ended up with a good class 2 molar occlusion, class 1 canines, and a decent profile with good chin. I don't see any reason why this should be unstable because we have sticked to the same arch form, we haven't flared any teeth, and everything looks the way within the alveolar bounds. So, you can see the cephs and the OPT, we have uprighted most of everything, and the teeth look very well inclined. 2 years later, as you can see the superimpositions as well, good amount of intrusion and a good counterclockwise rotation of the mandible has happened. 2 years later, she's still pretty much stable, and that is what is the best part about orthodontics. You need to not just finish a case well, you need to see it retain well as well. You can take pictures of the slides that have the camera over, just in case you want to have a look at the publication as well. Now, the next frontier that we have these days is a lot of MARPE, and at the same time, we're just not talking about class 2s, we're going to be talking about a lot of class 3s as well. You see, I've been a clinician most part of my practice, and I've realized that one thing which is almost impossible to achieve in adult patients, in class 3s especially, is maxillary advancement movement, right? Not adults per se, but even in adolescents for that matter, probably once the suture closes. But with the advent of MARPE, or mini screw supported expansion, we disarticulate the pterygopalatine sutures and the circummaxillary sutures at the same time. So I don't see any one reason as to why the maxilla cannot be brought forward. I do know a lot of researchers may disagree with me, but then still, we need to do what is the best for the patient. We have this very young girl who had come in with a chief complaint of being bullied with a severe class 3 malocclusion. She was 14 when she came in for the consult, and the main complaint was obviously that she was bullied. Now, looking at her particular dentition, I had a thought that this has to be a severe skeletal class 3 with a familial tendency. So I asked around parents, grandparents, nobody had that, but she definitely has a narrow arch. And she asked me that you need to do something about this. I have two options. One, tell her, I can't do anything, wait for the next 5 or 6 years, and then we're going to go for some kind of a surgery, get bullied for the next 5 years, or we do something right now, and still you may end up with some kind of a surgery, but it's a win-win. I'm going to do something about it right now. So, looking at it, it's a very high angle case. Now, what we did in this particular case, I think I do have a slide missing, but yeah, we went in for the MSC. Now, why the MSC is obviously because we know that whenever you have an MSC, you have a more bodily expansion of the molars compared to buccal tipping. Even with a SAME for that matter, or a SARP, you have a V-shaped expansion and not a more parallel expansion. But in this case, we use an MSC, we try to disarticulate, open up, And also the best part about an MSE or a MAPE, it has a AP component. It has a sagittal component in which your incisors are pushed forward at the same time, which corrects a lot of this class 3, if not the whole of it. Now you may question why I used a face mask and not Bollard plates, because obviously a face mask has a chin cup which is further going to rotate the mandible downward and backward. But I have a logic to this, and I believe that it's not like a twin block. A twin block, for that matter, pushes the mandible forward and has a high chance of relapse because there's nothing holding it back. It can still come back anytime. But when you have a face mask, you jump the bite, and once you jump the bite, the chances of it going back are very less. And more so because I've used a MAPE in this particular case, I also had an added AP component to retain it in a different way. Once we did that, we were able to jump the bite, obviously, and then came the conventional orthodontic treatment. Obviously, in this case, there was still a space deficit even after MAPE, and so I decided to extract premolars after expansion. Expansion with MSE, MARPE, or whatever does not guarantee that you go non-extraction. No appliance guarantees that it's non-extraction or extraction, because that's a diagnostic issue. That is not a treatment planned issue. So it's a very different game that we're talking about. So we extracted in this particular case and closed the spaces, gave her a decent occlusion. She's still high on the mandibular plane, but when you look at the post-retention 2 years, she's still very stable. Now, question. How many of you would go for a rapid palatal expansion and not a MARPE on a 14-year-old? Raise your hands, please. Would anyone have expanded this case differently? No? You would have with a RPE? With a? Yes, a bonded RME. It could have been used as well. But I'll tell you why. First of all, we have this paper which clearly shows that obviously you have more skeletal effects than dental effects, and moreover, your buccal inclinations are way lesser when you use a MAPE, because buccal inclinations again would amount to increase in the vertical dimension because you have premature contacts, and you would further rotate the mandible downward and backward, and so on and so forth. But more importantly, you know what? Literature teaches me lesser than what clinical experience teaches me. I had one case of a 14-year-old which I treated with an RPE, and I saw expansion happen within 24 hours, to such an extent that it caused a scissor bite, and I was so happy. But then I looked at it, and it was an asymmetric expansion. And then I got scared, and I was like, something wrong has happened. Then what I did is I called the patient to the clinic, and I just held that segment, and it was moving like butter. That means I had fractured the alveolar plate. Do you see the fracture? You can clearly see the fracture. It's a through and through fracture. And this happened because I have done an RPE in a 14-year-old many times. It has happened, it has worked out very well in a lot of patients, but it didn't in one. And that one taught me enough not to do it ever again. Because I don't want this kind of a situation to happen again. And that is exactly one of the reasons why I don't use an RPE or any of that sort of expanders on a 14-year-old anymore. The second part of my lecture deals with curve of Spee corrections and different facial patterns. I'm sure everybody knows curve of Spee. Everybody knows what a curve of Spee is. Everybody does. But what do you do knowing the curve of Spee? Let me tell you, through the course of these two cases, why knowing how to treat curve of Spee is so important. We have this 40-year-old lady with a severely high-angled mandible and a class 3 malocclusion, again with some prosthetics on the upper arch and knife-edge ridges on the lower arch, missing molars, and she did not want implants placed over there for monetary issues. I love these two papers by Paolo Cosa et al. In the AJO and in the EJO, which talks about the curve of Spee. Now, the curve of Spee is so important. What we do is we place a flat night-eye arch wire in most of these cases to correct a curve of Spee. That's all we do. But what happens is very different based on the mandibular plane angle. on a high-angled mandible, when you put a leveling arch wire, which is an 016 wire or an 014 wire, what do you expect? How do you want the curve of speed to correct? You want the molars to extrude. You don't want the molars to extrude. You want the incisors to intrude in order to correct the curve of speed. But do you think that naturally happens? That does not happen. Because of the loose and lax muscles and the very poor occlusal forces on a high-angled mandible or a hyperdivergent case, what happens is that the molars freely erupt to an extent of, say, 2.5 millimeters, and the premolars extrude 3 millimeters on an average. Now, can you imagine what 3 millimeters of extrusion does to your anteriors and to your mandibular plane? It really pushes it downward and backward. But we don't care, because that's leveling alignment. You just put a night-eye arch wire, you're going to close spaces later. But you have to think about it, because if you don't think about it now, you've already increased the facial height, and that's going to stay the same. You're not going to change it ever. So, what do we do in such cases? What I do in such cases is, the first thing is I put a bite block on the molars, because putting a bite block on the molars makes sure that your molars are not going to erupt. Number one. Number two, I place a tad somewhere between the premolars, and I tie a ligature wire right from the tad going up to the base arch wire, so that I make sure that the premolars don't extrude anymore. And now what I do is I would give a light retractive force, or just leave the night-eye arch wire, because all the wire can now do is intrude or tip the lower incisors back, because that's what I'm forcing it to do. And obviously, space closure mechanics is pretty much the same over here. What I do is I place a gable bend distal to the premolars, increase the alpha moment on the premolars so that they are measly thrusted, and at the same time it gives a tip back moment on the molars and a power chain to slowly just pull it forward. It's that simple then. So I was able to close these spaces, and I was able to close the knife edge as well. I'm sure that there would be very, very less amount of bone surrounding those molars, but I had definitely told the patient that that is something that you need to consider, because I might close the space, but the bone coverage is something very questionable in such cases. Now, on the contrary, this is 2 years into retention. Luckily, she's pretty much stable. No changes in the post-treatment and post-retention. And you can take a picture of this if you want to have a look at this case report as well. On the contrary, let's talk about what happens on a brachycephalic patient with a very, very strong musculature and a severe class 3 malocclusion with a deep curve of speed, retruded lower incisors, and no surgery again, because they don't agree for surgery. Brachycephalic patients, on the other hand, have such strong occlusal forces that what you want when you place a night-eye arch wire during the initial stage is you want the molars and the premolars to extrude. Unfortunately, that doesn't happen. What happens is that your lower incisors flare, procline, and when they procline, it's disaster, especially in such a case. So, one easy way of how I usually correct such cases is by placing a bite block on the lingual aspect of the lower incisors, because the occlusal forces are so strong that they don't let the lower incisors procline anymore. I give some kind of a bite opening and I force them up with elastics. And mind you, even with elastics, it's horribly hard to pull these molars up, because I have done this for a year. The molars come up, they go down. They come up, they again go down. And finally, I put in a lot of Botox on him. Now, Botox deactivates those strong muscles and temporarily helps me push it up. I wouldn't say that I got a 100% result in this particular case, but I would say that I may have pulled it up, say, 4 to 5 millimeters, but the resultant extrusion may have been just half of it, say 2.5, and I was more than happy with what I got. But again, it's basic physics. If you pull something up, the teeth will go forward. And if I'm not letting them go forward, it needs to go somewhere. And that is why we place the buccal shelf, extract third molars, and distalize at the same particular point. Distalization helped me gain that space for the curve of speed correction and correct the inclination of the lower incisors, and I was able to attain a good, satisfactory outcome for this particular class 3 case. Now, this is how I control the curve of speed in different vertical dimensions. This is what I was talking about, the Botox. You can just take a picture, and it's a wonderful treatment strategy, especially in certain amount of cases, especially when it comes to brachycephalic treatment. Now, let's come to the third aspect of my lecture, which is the incisal and gingival display. It's very common these days to now see that, or at least a lot of patients come with concerns of gummy smiles. Because I think social media has a very, very big impact on everybody's lives. We see a lot of influencers who are very beautiful, who are very smart, and we try to emulate, we try to become them, and everybody wants to have dentitions and smiles like them, which is very natural, which is very, very natural. Intrusion of the whole arch in order to correct a gummy smile is not a very new treatment strategy. It's very old. We do intrude teeth. We do treatment of vertical maxillary excess, which was primarily surgery, which needed a Lefort 1 surgical impaction in the first place, which is the ideal treatment, which is pretty stable as well, by the way. But then what happened is intrusion helps us in many different ways as well. But we need strong research and reasoning before we can intrude teeth and say that it's going to stay like that for the rest of your life. Dr. Ki-Jun Lee has been a pioneer in this particular field, and I love this paper by him in the BMC Oral Health, the stability of vertical dimension following total arch intrusion. Dr. Farella over here sitting, he doesn't believe me. He doesn't like intrusion. He says it doesn't happen. But then, superimpositions don't lie either. I can't come out with a randomized controlled trial, for sure, but then it's just going to be superimpositions for now that you need to be happy with. What he found in this research is he measured the upper first molars when they intruded, the upper incisors, and the changes in the lower anterior facial height. Now, after intruding, he came to a realization that the most stable of them are the intrusion of the posterior teeth. And the least stable is the intrusion of the anterior teeth. The lower anterior facial height also relapses with time. When you look at the numbers, he found that obviously intruding the entire arch with 4 screws or 6 screws is very significant. You get a significant clinical change post-treatment. But does that translate to post-retention? Does that translate to 2 years later? Is the bigger question. Because you can be happy just treating a patient one day and you can say bye-bye. Like I left Cambodia for New Zealand. But then, at the end of the day again, it's a big question mark. What if the patient comes back to you 4 years later and says, boss, it's come back. I'm not happy. And then you'd say, now it's surgery because I can't do anything else. What he found out was that the upper one, the molars rebounded, sorry, the upper one, the incisors, relapsed 43%. 43%, that's almost half in 2 years. The upper posterior teeth showed the minimum changes. That is just about 16% relapse. That means they're very stable. And 70% of the lower anterior facial height was maintained. That means it relapsed only 30%. So what do we learn from this? What do we learn from this? Should we stop intruding teeth with mini screws? Because it's going to relapse 50%, isn't it? Is it worth being done? Do we need to do it? I would say it is. Because what's the other alternative? The other alternative is a Lefort 1 osteotomy with impaction. Would you want to undergo that? Or would you be okay with a 40% relapse? A 40% relapse, for me, means I corrected to 130% rather than 100%. And so I can still achieve what I want to achieve, right? I think you would agree with me, isn't it? So, I would still love to intrude teeth and correct certain amount of vertical maxillary excess cases with intrusion. All I would do is I would rather overcorrect these teeth a little more. With that in mind, let's look at this case of a 53-year-old lady who wanted to look beautiful. She came with a scissor bite, a typical vertical maxillary excess, heavy band of gums that you can see over here, mutilated dentition, deep overjet, overbite. First thing, as I mentioned previously, scissor bite. I used a Schwartz appliance in this particular case. I'm sure everybody knows what a Schwartz appliance is. It's a removable appliance. And usually, one thing about these patients who come in their late ages is they're very compliant because they want treatment at that age, right? So they're going to be very compliant with what they're told. She wore the Schwartz appliance. I gradually expanded the screw. But can you expand the mandible? There's no suture in the mandible to expand. All you're going to do is upright the posterior teeth a little bit, if you want to call that arch development. You can just upright the molars a little bit, but that's enough for a scissor bite correction, and that's all I was hoping. But that relapses, right? So she wore it, and then I retained it with crossbite elastics, as you can see, at least for the next 3 or 4 months, because I didn't want that to go back. This is after 4 months of crossbite elastics. She's pretty much stable. And then what I decided was place 3 tads, center, sides between the premolars and the molars, and then retract and intrude at the same time, because this is a very, very simple mechanics. There is no complications over here. I mean, you could use 2 tads, one between the laterals and the canines, or you could, I use it between the laterals and the centrals, and I'm sure Dr. Madhur is going to be explaining which is better, which technique of placing the screw is better, and we would all love to learn that from him. But I usually end up placing the screws between the centrals and the laterals, or between the centrals, and intrude. In a matter of time, 6 months, 8 months of intrusion and retraction, I was able to gradually close these spaces. It's a little slower in adults, I must say, but then it's not impossible. And then you have these big bony exhaustosis forming. I mean, I'm unlucky, or I don't know if it's very common, but most of my cases have alveolar bone exhaustosis. Maybe I'm doing something wrong, maybe you're doing something right, I don't know. But then, the only way you can correct this is by reflecting the flap and by using a carbide burr and shaving the whole damn thing. And while you're at it, you could do a gingivectomy as well. Because I told you that I'm a fan of gingivectomy, and I believe that the changes that you attain after that are far, far better than before. Finish that, close the spaces, and now I can claim that I made her look 10 years younger. You see, in the beginning of the Dunning-Kruger, I was very confident. I did things the wrong way, and I made the patient look 10 to 15 years older, as you'd seen. And now came, when I crossed that stage and I was climbing up, when I looked back, and I made a 53-year-old look like a 45-year-old. So that is something that experience would do to you as well. Similarly, a young girl, heavy vertical maxillary excess, about 10 millimeters of gum display, but she also had short clinical crowns. And I'm going to run you through the mechanics of this particular case. You won't believe, I've told this a million times before. But then, I was so influenced by social media in my initial years of life that I wanted to do every damn thing non-extraction, as many of you. I had seen on Instagram a beautiful, I'm not going to name the orthodontist here. So he does these wonderful intrusion cases with mini screws, right? And he never extracts. And I'm wondering, where does he get the space to intrude? But I was like, I'm not going to be using those same brackets, but I could try on MBT brackets. By the way, I use these brackets by 3M, the wires, especially as Dr. Narayan mentioned as well. I love those wires, the super elastic wires. They're very, very good. And what I did was I used I torqued the incisors negatively because I knew that intrusion is going to procline those incisors. So I'm going to probably just give them a little negative torque. And I'm going to try to pull them up as much as possible because it should work, right? I mean, a low torque bracket is almost the same as negatively torquing the wire. I don't see the difference because I'm a tweed guy. But then, when I did that, I started opening the bite, as you can see, and I started flaring it. I mean, there was no way the teeth could go anywhere, no matter how much. I mean, I don't understand the concept of high torque and low torque when there is no space. You need space to have teeth movement. You can use whatever torque you want to use, but without space, where is the root going to go? It's just going to come out of the bone. And probably that's what happens. When you use low torque brackets and you use all these intrusion and fancy mechanics, what happens is the roots are out of the bone. And you don't see that because you don't take a CBCT after. And even if you do, you always have the justification that CBCTs over-exaggerate everything, don't they? So yeah, it does matter, by the way. So I intruded these teeth, and I started seeing an open bite. I started seeing teeth flare left, right, and center. And I decided, no more. What I'm going to do, and this is where I ended up with. So I created a wonderful open bite and flared incisors, and I'm now going to round trip. Round trip means 1.5 years of waste. I placed the TPA 7 millimeters again, good clearance, because I wanted the tongue to act a little bit. Again, I'm not going to claim that works. It works for me. In certain cases, it hasn't worked in many cases, and where it doesn't work, I put in an implant, and then I pull it up on the palate as well. And this is the best thing I did for her. I extracted 4 teeth. And when I extracted 4 teeth, things became so wonderfully easy for me. All I had to do is intrude, pull back, close the space. You can see, and I've told this a million times before as well, intrusion of molars cause counterclockwise rotation of the mandible. Now that's a given. But in this case, and when you have that, what I'm trying to say is, the overjet is definitely going to reduce, but at the same time, the open bite is supposed to correct, because you would see that kind of a rotation happening. But in this case, I wasn't seeing that happening. And I was wondering, why isn't that happening? And then I realized that even with that wire on the lower, now people ask me, how does that happen? I don't know how that happens, but then the lower molar still extrudes, even with the wire. And it's passively erupting into that intruded space of the upper molars. So unless you have no contact at the back, you're not going to get that rotation. So I put in 2 more implants. Now you might call it an overkill, I don't. I placed 2 more implants on the lowers, and I at least tried to intrude the lower molars. Now lower molar intrusion is not very easy because the first thing you get is buccal tipping of the lower molars. You have to be very careful in making sure that they don't tip buccally. So the forces have to be kept very, very minimum. You probably have to lingually torque the wire so that you make sure that the molars don't just buccally tip while you're intruding the lower molars with mini screws. And voila, once you did that, I saw the bite just close. And once that closed, you can see things became very simple. Now I know Dr. Narayan may not agree with me on this, but I like to measure, and I like to at least think that implants are going to stay stable for measurement. But then Dr. Eric's research has proved that they move as well. So, yeah, I'm not very sure as to how much of intrusion I've got. But then I also did some gum contouring on her, which made things easier, which gave her a better smile. And at the end of the day, I was able to achieve a very good consonant smile for her. Now you can see, what I'm going to show you is this. Do you see the mentalis strain in the pre? And do you see almost no mentalis strain on the post with a chin? Now that is because the lower anterior facial height has reduced, and when the lower anterior facial height reduces, you get a relaxation of the mentalis muscle and a chin projection. I've written a lot of this in my seminars paper titled The Gummy Smile Etiologies, Diagnosis and Formulating a Clinically Effective Treatment Protocol, which brings me to my last case. Before that, I want to ask you all, how many of you use class 3 elastics on a class 3 case? Please raise your hands. Right. How long do you use class 3 elastics on an average on a class 3 case? It depends on the situation. But I have seen a lot of these philosophies which train you to use early elastics from the very word go and continue till the end of treatment. And when you do that, during traditional camouflage treatment, employing class 3 elastics, the extrusion of maxillary molars and mandibular incisors rotates the occlusal plane counterclockwise, decreasing the maxillary incisor exposure and compromising the aesthetic outcomes. So, I used to do this a lot. And I realized that post-treatment, all these class 3 cases started showing almost no incisor show and an increased lower incisor show. Something was really wrong. And then, also when I use buccal shelf implants, I know that because the head stays occlusal to the center of resistance, retraction causes extrusion of the incisors and intrusion of the molars, again causing a similar effect. So what do? At the end of the day, aesthetics is also very, very important. You just don't end up in a functional occlusion with a bad smile. I mean, that doesn't help the patient. They don't care what the functional occlusion is or what the occlusion is. They want a good smile as well. I'm not saying that's not important. That's also important. Which brings me to this case. This patient came to me. She's a young 23, 24-year-old girl with a typical skeletal class 3, no functional shift. You can see class 3 molars, class 3 canines, a widely round upper arch, and a decent enough lower arch. Now, how many of you would extract to correct this class 3? Please raise your hand. Again, very few. Okay, so again, I would stand with the very few people because I love extracting teeth. Not because I just love it. It's because I don't want to tax the bone around it in certain amount of cases. Now this case for me was an extraction case. You can see that she's not smiling well, but you can still see the risorius muscles and the activation, that even if she would have smiled, she wouldn't have shown her upper incisors at all. She wanted to show her upper incisors. That was a chief complaint. She said, I want a smile in which my upper incisors need to be shown. You can see a pretty decent occlusion over here. There's not much to it. I mean, she's not a very high angle. She's not a very low angle a patient, and pretty upright teeth. So what I did in this case was I tried something different. Now, I have done this on many other patients with similar results, but I think the most drastic result was in her, and that's one of the reasons why I'm showing this to you as well. I extracted the lower premolars in this particular case. What I did was I obviously, while retracting, you need to raise the bite in such cases because it's a class 3 component. I mean, you can take care of, you can use the freeway space, but it's just better to raise the bite so that it makes retraction kind of easier. Now, with that, what the most important thing what I did was when I got some amount of retraction and I corrected the overjet by retraction, I stopped. I took off the bite turbos from the first molar and the second molar, and I left it only on the premolar. So that kind of gave you a tripod effect, if you know what I mean. So you just have the bite block on the premolar, and you don't have it anywhere else. So it's like hinging on the premolar. Now, you have a very rigid upper wire, which is tightly ligated. So that makes it one unit, if you know what I mean. And the lower, obviously, it's not a unit because you still have spaces. And now with that, I use class 2 elastics. So when I use class 2 elastics, it kind of rotates the occlusal plane completely downward. Because I have made that a unit and it's a tripod that is functioning on the premolar now. So it kind of rotates the occlusal plane down, and the class 2 is going to pull the molar forward. Now you can debate all you want as to how class 2 elastics are going to protract molars, mesial tipping, extrusion a little bit. Yes, I agree. Now there are ways of correcting that. You could put a tip back bend, you could correct all those things. You could have a gable bend as well. But then, the purpose of class 2 elastics was definitely to close those spaces. But you wouldn't believe, obviously the spaces closed, and once they did, I took off the bite turbo from the premolar. I had an open bite in that area because I had a bite turbo there. I just used V elastics, 3x16, 1x8, short elastics, 2.5 ounces, 4.5 ounces, and closed that bite over there. But what happened here was that I changed the occlusal plane more than anything else. So this was not a very class 3-ish treatment, more like a class 2 elastic usage on a class 3 treatment. And why I say this is because I love using class 3 elastics as well, but what I do is I limit those class 3 elastics to the very later stages of my class 3 correction, because I don't want that counterclockwise rotation happening on a class 3 case. I ended up with this kind of an occlusion, which she was stunned. She loved this kind of an occlusion. She also had a gum contouring done, and at the end of the day, she had a good occlusion, not much of a change when it came to the lower occlusal plane, and a good smile line, and yes, definitely a good treatment the way I see it. So, why did I put this slide over here? Throughout the 2 days, I heard, let the wires cook. Let the wires cook. Let the arches develop. Let the wires cook. I believe what needs to cook well is a pizza. And Dr. Mauro Farella over here cooks one of the best pizzas. As you can see, this is his home. And he usually gets us over here and he treats us to varieties of pizzas. Am I saying this right? Margarita. Yeah, margarita. Delicioso. That's exactly how he says it. I'm speaking on the very same topic in CERO. Thank you, Dr. Ute, for having me as well. And at the AAO in Philadelphia next year. That's all, folks. Thank you so much for having me here. Thank you so much, Dr. Shetty. Thank you so much, everybody. It's a wrap from my side.
Thank you, Dr. Venugopal, for a wonderful presentation. You have expanded our envelope of knowledge in vertical plane. On a personal note, I would like to share a common incident happening in our department, Government Dental College, since last few years. My postgraduates are very fond of you and your articles. The moment your article is still in the press, they come to me seeking permission to present it as a part of journal club, like TAD-driven class 3 camouflage 8-point protocol to optimize efficiency, then alternative treatment strategies for pseudo class 3 with mild asymmetry, and so on. Thank you once again for the wonderful presentation.
I request Dr. Naushi, sir, to give the certificate and memento of appreciation to Dr. Adith Venugopal, sir. Also, I request Dr. Mukesh Kumar, sir, to come and give the certificates to the chairperson.